Bismillah ar-Rahman ar-Rahim. We will start the second day of our CRACE presentation. We have today our dear eminent professors, Professor Bjarne Odd, Tampere University, Finland, and Professor Zaim Siddiqui, Alberta University, Canada. We thank them so much for coming in this very tight time for them and their schedule, and they insist to come and to be with us in this school and conference. Thank you so much, professors. Okay, we will start with the first case, please.
Good morning, dear professor. May I introduce my case? Mr. M.A.H., 63 years male patient, married with 2 offspring, right-handed, retired with no special habit of medical importance, complain of muscle cramps, family history, no consanguinity or similar condition, nor other new psychiatric illnesses, past history hypertensive, oncotar, compliant and controlled, carpal surgery, history present illness, condition started in gradual onset, progressive course of 5 years ago, when the patient started to complain of glove and stocking hypothesia, then 3 years ago started to feel muscle pain, mainly in his lower limbs, increase with a long standing and while walking, which wasn't his usual. 2 years ago, started to account on muscle cramps, especially during sleeping and mainly in both lower limbs. Meanwhile, patient had myoclonic jerks in both limbs during sleeping. Examination, generally, no abnormality detected. Neurological examination, mental state examination, conscious alert oriented, no myotonic features, speech, no dysarthria or dysphasia, cranial nerve examination, no cranial nerve affection, no facial muscle weakness or extraocular muscle affection, nor tongue atrophy or fasciculation. Motor examination, state, muscle tenderness and pseudocalf muscle hypertrophy, no muscle atrophy or fasciculation. Tone, no tone changes around joints, power intact, reflex elicited all over, bilateral flexor plantar, coordination intact, sensory examination, bilateral high glove and stocking hypothesia, and periumbilical hypothesial gait, no abnormality detected. Extraocular and extraocular muscle and facial muscle, no weakness. And power distal and proximal intact. Reflexes elicited. And sensory, glove and stocking and periumbilical hypothesia. الجيت. Investigation, labs, lactate elevated.
Just a moment. Can you tell us just formulation of your cases before the investigation?
36 years male patient, past history with hypertension, complaint of gradual onset progressive course of 5 years duration of muscle glove and stocking hypothesia, then muscle pains and cramps, myoclonic jerks.
Okay, so the main complaint is the muscle pains and cramps.
And
okay, and he's presented with hypothesia, glove and stocking hypothesia.
Yeah.
Okay, he only has 6'6". He's how old is he?
63.
63 years old. So before the investigation, what is your diagnosis? What is your provisional diagnosis?
Metabolic myopathy, mitochondrial.
Why metabolic myopathy and why mitochondria?
Muscle pain and cramps, well, myoclonic jerks.
And?
Myoclonic jerks.
The myoclonic jerks. So you thought this could be a mitochondrial disorder?
Maybe.
Okay. What about your investigation?
Lactate and pyruvate elevated 52 up to 12, pyruvate 1.1 up to 0.9, BTH elevated, mildly elevated 83 up to 80, vitamin D normal, CBK normal, thyroid profile normal, alkaline phosphatase normal, nerve conduction suggestive of lower lumbar radiculopathy, EMG normal, autoimmune myopathy panel negative, molecular genetic testing suggestive of ALS.
Can we see, no wait, can we see the, which gene? Or if you have the result, we want to see which gene. No, wait. The main complaint of this patient is 5 years duration of muscle pains and the cramps, and occasionally myoclonic jerks. And for 5 years, they don't know what is the cause of his illness. Another one? I want to see the genetic testing. Do you have, Radwa?
What is on these papers?
Yes. I can try to find with me. I will search. Okay, I have it. محمد عشمان مش كده. They found this gene. I can see. Okay, I can read to you. Okay. Yes. TRPM7. هم لقوا gene mutation. Unknown gene. TR.
To me.
To you, okay. TRMP7. And they said this is autosomal dominant, can cause Parkinsonism and dementia and ALS. يعني هم لقوا gene mutation ممكن يعمل ALS. I'm sorry?
Calcium level.
Calcium is okay. Calcium is okay, but the parathyroid hormone is high. Yes.
So, has to be people with the acquired part of that? Why do you think it's genetic? Like, what about acquired metabolic, very high parathyroid?
Sometimes this happens with vitamin D deficiency, and I think he had vitamin D deficiency, and we corrected it with this vitamin D injections, but still the parathyroid hormone is high. So I think this is the main cause. Calcium is normal now. But we were searching why he has these cramps and myoclonic jerks. So we found that the serum lactate is high. And we did for him muscle biopsy, and we found that was some only very small angulated atrophic fibers. ممكن تجيبي اللي بعدها؟ wait يعني مش عارفه هم جابوها في ال very small angulated fibers and no necrosis, no inflammatory changes and no mitochondrial changes. هاتي اللي بعدها. لا اللي بعدها دي اللي قبلها. بس هم دول؟ We were searching for a mitochondrial changes. We didn't found. Only small atrophic fibers like that of neurogenic affection or ALS. And they only...
But you don't have any groups of atrophic.
No groups. Scattered.
You also have sensory, glass fucking hyposthesia. How do you, that suggests a peripheral neuropathy, that, no? If you got somebody with a peripheral sensory loss, what's the nerve conduction show? Does he have any?
What does the nerve conduction only show radicular neuropathy. Lumbar radiculopathy only.
Sensory response was normal?
Yes, but the pains is all over the body, not only in the periphery. And I think he is not diabetic, Radwa. He is not diabetic.
You also know cholesterol lowering medication, by the way, that can give you cramps too.
Yes, we give him a lot of medications and no improvement. Some consultants say it could be a psychiatric condition, but when we found the the serum lactate is high, and these few atrophic fibers, then we did this genetic mutation. We found a strange gene for ALS or Parkinson or dementia. We said maybe a new condition. We don't know.
I think
No, no, this for you.
here we have a case which is not unusual as those who present to neurological examinations, a case with more symptoms than findings. And you have always trouble to make correct connections. In these cases, it is more easy if you have more findings than symptoms. Of course, we have always great interference with sort of psychogenic factors having impact on your symptoms, and you can never exclude such possibilities. In this case, of course, what you have as finding is, I think, the calves were a bit big, so calf hypertrophy to some extent, maybe, and the lactate level, I would check many times, because you can have variable results by one testing, and also I would do an exercise test to see how the metabolic parameters act, if that's a real finding or not. To me, also a complexing part of the story is that he has sort of sensory symptoms, but no changes. No changes, no changes on neurophysiology to explain those symptoms. And then you are in trouble to know what is really the issue. We have many patients with myalgias all over the place, and one of the first diseases we understood were causing myalgias. The main complaint without muscle weakness was in fact myotonic dystrophy type 2, which also may cause big calves, but usually you have some EMG findings as well to accompany for that. In this case, EMG remained normal, so no sign of muscle damage. And after that, we understood that the complexity of how ion channels can mediate symptoms also came around. You know, ion channels most from the clear-cut myotonias with sodium channel mutations or chloride channel mutations, and then we have the calcium channel abnormalities causing other types of problems. In fact, some of the sodium channel mutations can cause myalgia without any sign of myotonia. This would, of course, be in the larger spectrum of considerations why the patient has myalgia. I would definitely also do a muscle MRI study just to know that there is no sort of tissue damage and degenerative changes, and then you can at least reassure the patient because then the prognosis is good, irrespective of how many symptoms there are around. So I'm not sure, I don't think the genetic variants you have identified can be responsible for it.
You don't think this, it could be a form of motor neuron disease or ALS, because he was afraid that it could be a motor neuron
Yes,
disease or ALS.
that's the one problem for all patients when starting to have some symptoms from your neuromotor system at the advanced stage. But in this case, normally, I would say always, you have EMG findings before you have symptoms in ALS. So I would not be very much afraid of ALS in his case.
So, Professor Ott, you suggest we do MRI muscles for the patient to see if there is a tissue damage, number one. Number two, we can do exercise tests, for example, to search for a metabolic myopathy. Or metabolic
And to
disorder.
check what the now notified increase of lactate, what it means.
What it means is
Was
that-
it a incidental finding of some type, or?
Okay. We have this in the National Research Center. We have a special unit to the metabolic disorders. Our colleague, Dr. Ayman Kilani, he can do for him to explain these metabolic changes, and he can do a exercise test. Dr. Ayman Kilani in National Research Center. And we'll reassure the patient this genetic mutation has, until now, has nothing to do with him, and he is not a form of ALS, and this is the question of the patient. I'm not a form of ALS or a motor neuron disease. It's okay. It's okay. Thank you so much. Thank you.
There was also a question about
uh,
myoclonia. I did not see any myoclonia on the videos, but apparently he has
He's exaggerated his condition. Yes. Dr. Sarah Hamdi, she has our assistant lecturer, neurology. She will present to us the second case. And slowly and loud voice.
Did you have any myotonic dystrophy type 2 in Egypt? We had one patient coming for one conference a long time ago, but he came from another country.
He was from Saudi Arabia.
Yes.
Yes,
We
but
diagnosed with.
I failed to find myotonia type 2 in Egypt until now. I don't know because of the genetic testing or what, but I failed to find. So maybe you can guide us today how to find myotonia type 2 in Egypt, because I'm sure we have many patients with pains and myalgias of unknown cause. We don't have the genetic testing till now. Maybe this is the cause. Maybe.
So, I mean, if you have families with reoccurring symptoms like this, and in the older generation you have some with cataracts, then you can go for the testing. Actually, it is very problematic to exclude by other means than genetic testing.
Yes,
And
it
it's
is
a repeat.
nucleotide repeats. Yes.
So it's
It is done by
tricky.
thousand blotting.
There are other methods as well.
Okay.
So there is a two-step diagnostic method. You first check if you have one or two copy of normal alleles without the expansion. That is easily done by a PCR test.
what they said, long PCR test, something
No,
like
no,
that?
no,
No,
that's
normal
different.
PCR.
Normal, just to
Normal
check
PCR.
how many normal alleles. So if you have 2 copies of normal alleles, you don't have the disease. If you have 1 copy of a normal allele, then you are a suspect. You can have that also for other reasons than the mutation, and then you have to go do the next step, which is a repeat primed PCR test where you really pick up the expansion.
I hope you can supply us with the test, because
It's published and it's
okay. Because maybe
yeah.
tomorrow we have Professor Zaim, we have a new center, we have Masri Center, and it will be specialized for genetic center. So we started to train them for our neuromuscular disorders. So maybe we can, they have the equipment, of course, and they have the personnel, and they don't have the, so maybe we'll try to give them some methods so to diagnose these diseases. Okay, يلا يا سارة.
MAE, 10 years old male patient, student, 5th primary with good scholastic achievement. He's single, lives in Al-Anatar, no special habits of medical importance, and he's right-handed. Developmental history, prenatal, natal, postnatal history, past uneventful, with normal developmental milestones. Complaint bilateral upper limbs and lower limbs weakness. Family history, there is positive family history of consanguinity. They are second degree relatives. Mother had positive history of recurrent abortions, both in first and third trimester. No family history of similar conditions, no family history of other neuropsychiatric illness. Past history was irrelevant. History of present illness, gradual onset, progressive course of 3 years duration. Condition started in 2019 when patient developed 2 attacks of epileptic seizures during sleep. There was tearing loop with post-ictal confusion. Patient sought medical advice and was prescribed Tegretol 100 milligram twice per day, on which he is controlled and never reoccurred again. 1 month later, patient complained of bilateral upper limbs of symmetrical distribution, but proximal more than distal, but also distally is markedly affected, associated with decreased tone around wrist and elbow joints, no atrophy or hypertrophy or fasciculations to a degree he couldn't raise heavy objects above his head. Few days later, mother noticed also lower limb weakness, also proximal more than distal, also with symmetrical distribution, but no tone changes, no atrophy or hypertrophy or fasciculations. To a degree, he found difficulty in climbing stairs, yet until now, upper limbs are much more affected than lower limbs. Patient sought medical advice. He was prescribed oral steroids with minimal improvement. Patient didn't account on any sensory manifestations, any cranial nerve affection, no sphincteric disturbance, no speech problems, no cognitive abnormalities. Should I proceed?
Sarah, can you tell us summary or formulation?
He's
Because some of your colleagues in the back, they are not following you.
Our male patient is 10 years old with positive family history of consanguinity, and his mother has positive history of multiple recurrent abortions. Relevant past history, he presented with 2 epileptic seizures 3 years ago, followed by bilateral upper limb and lower limb weakness of symmetrical distribution, proximally more than distally, and also distally affected. No atrophy, hypertrophy, fasciculations. No sensory manifestations, no cranial affection, no speech problems, no cognitive abnormalities.
So this proximal weakness of upper limbs only, and
Upper limbs and lower
but
limbs,
more in upper limbs.
but more in
Is
upper
there
limbs.
any distribution, any selectivity,
No, all muscles are affected in all movements.
and there is atrophy, fasciculation,
No atrophy, no
atrophy, no
fasciculations, no cuff
and
pseudohypertrophy.
no capsular? What about the reflexes?
They are diminished. Should I proceed to examination?
Diminished. Okay.
General examination, it was irrelevant except for the side effects of the long duration intake of steroids. He had cushingoid faces and central obesity. Neurological examination, patient is conscious, alert, oriented to time, place, and person, no speech abnormalities, and the cranial nerves are intact. Motor, no atrophy, hypertrophy of circulations. Tone, there was hypotonia, severe hypotonia in upper limbs, but not obvious in lower limbs. Regarding the power, bilateral upper limb weakness, right equal to left, proximal grade 2, distally grade 3. Lower limb weakness is better, distally grade 4 and proximally grade 3. Dr. Nagia, I do have the patient. Should I bring him for
Continue
demonstration?
The examination, then
Okay.
bring the patient.
There is truncal muscle weakness. Regarding coordination, intact, no involuntary movements. There is waddling gait and positive Gower sign. Reflexes, deep tendon reflexes lost all over and bilateral flexor plantar, sensory intact all over, both superficial and deep.
So, what's your opinion after your examination, before the investigation? What's your opinion? What do you think? It's a neurogenic, myogenic? Which disease? Where is the lesion and what is the lesion? Your opinion about the patient before the investigation.
Before the investigations, I would think about myogenic disease or muscle disease.
Why?
Because of the proximal muscle weakness, because of the hypotonia in both upper limbs.
But Sarah, there was no selectivity.
There is no
There
selectivity,
is no
yes.
evidence that this is a muscle disease.
Mm.
So you have to search for other lower motor neuron lesions, like
Peripheral neuropathy, for example.
but it is more proximal.
Proximal, yes.
Okay,
CIDP or
CIDP.
it's,
What about a form of spinal muscular atrophy?
or
for
spinal
example?
muscular atrophy.
What
maybe.
about this? It is
But no fasciculations, no atrophy.
okay, and there is hypotonia and there is diffuse weakness. It could be. Why usually when we found a proximal lesion, it must be a muscle disease?
Also, there are 2 attacks of epileptic seizures.
Ah, you are searching about the seizures. It could be related and not could be not related.
Mm.
But I'm thinking, where is the lesion first? Then I will say, what is the lesion? What's your opinion, Professor?
I mean, if you just have these this information of the sort of symptom history and your clinical examination, the situation is usually always the same. You can't decide if this is neurogenic or myogenic. You can't know. So you have to keep all options relevant until further examinations with neurophysiology and lab.
Professor Zaini, what's your opinion?
I totally agree. I think all options are there. He does have loss of reflexes as well, which is that right? The reflexes are gone.
Lost,
And
yes.
without any sensory changes, despite
No
that
sensory
severe
change.
weakness, there are no sensory changes. So that puts it in the myogenic category. Also, there is no atrophy of. If it had been a neurogenic case with that degree of weakness, you would expect a significant atrophy. So clinically, I agree with the presentation that it looks more of a muscle rather than nerve or a motor neuron, based on just a clinical presentation.
And when you have a situation like this with confusing situation and more weakness than clinical findings of atrophy or anything else, then you also have to consider the peculiar myasthenias. Yes, no, but you can have in Lambertitan you can have limb girdle phenotypes.
Okay. You want to see the patient
Can we think about muscular dystrophies? Sarcoglycanopathies, for example, or dystroglycanopathies, because of the history of epileptic fits with the muscle weakness.
Usually they start with the lower limb more than the upper limb. That's the sort of conventional presentation, but of course you can have unusual patients as well. But I would not speculate much at this stage without having more investigational data, because you can speculate on anything and it doesn't mean anything.
And also you have to consider mitochondrial myopathy also.
And
because
mitochondrial
of the
myopathy.
presence of this epilepsy.
Of course.
So your first investigation would be the labs, especially the total CK level. Then you have to go directly to the neurophysiology and search for all options that we said. Okay, Sarah,
CBC.
you can continue first, then we can see the chart.
Okay. CBC and chemistry were normal. ESR first hour 18, second hour 40. Thyroid functions normal. Lactate serum level was 6. Pyruvate serum level 0.2. Lactate pyruvate ratio was normal. CK total serum level 1 year ago when they did it was 646. The last one, and he was on treatment, was 337 on 26 June. HMGCR negative, pending myositis inflammatory panel. They said the laboratory investigations.
Okay, neurophysiology.
Echo normal, neurophysiology, nerve conduction, and EMG showed myopathic patterns, normal nerve conduction.
Normal motor and sensory nerve conduction.
Normal motor and sensory nerve
Waves
conduction.
also are normal.
Yes.
So it is a myopathic pattern. Lower limbs and upper limbs.
Yes, increased polyphysity and reduced interference pattern.
So you have small motor amplitudes. Okay.
Was there any spontaneous activity? As far as I can't see it. Was there any spontaneous activity in the EMG?
No,
Was there any spontaneous activity recorded? Does it say spontaneous activity? I can't see it in the EMG. Because that changes, when you see spontaneous activity in a muscle, that suggests a necrotizing myopathy, many muscular dystrophies. And they're congenital myopathies or myasthenia, which don't cause. So spontaneous activity in an EMG, needle EMG is critical because that does give us some information about a necrotizing myopathy where the muscle cells are dying as compared to congenital myopathies or myasthenia can give you a myopathic picture without necrotizing activity or fibrillation. So I can't read. Does it mention anything like that?
No.
The EMG?
Spontaneous activity?
No.
No, no spontaneous?
No.
Okay, so, but CK levels are quite high.
Yes.
That suggests
Yes.
Muscle cell death because that high, 100,000 of CK levels, that itself is a pointer of a muscle cell which is dying.
Disease, yes. So what
Yes.
do you think?
But for the normal childhood limb girdle muscular dystrophies and also for childhood myositis, the CKs are not in the thousands. So that will again sort of make a small hint towards something else than the conventional limb girdle muscular dystrophies and also severe myositis. And he already had a treatment for suspect myositis without any improvement.
So what about something like congenital myopathies,
Mitochondrial myopathies,
can
yes.
cause mild elevation of CK, and there is myogenic pattern.
All the other myopathies are in the range. All the other 800.
I think that level of CK elevation is very unusual for mitochondrial disease or whatever you mentioned. It is, I've never seen several hundred thousands. It has to be a dystrophic myopathy causing, yeah.
Did I read wrong? I saw CK levels on 600 and 300.
Once it was 600, it's
Yeah, no.
646, then decreased
Yeah,
to 300.
yeah, no, yeah, yeah.
Decreased
it's
serially,
just-
and he was
Just
on
mildly
corticosteroids.
elevated.
the highest level.
Yeah.
It's the highest level.
1
And
year ago.
That is why I sort of excluded the severe dystrophies. Yeah.
MRI muscle showed edema in posterior compartment below knee, fatty infiltration bilateral posterior thigh and bilateral posterior group arms.
لا تاني معلش بشويش كده عشان اللي ورا دول مش سامعين حاجه. الام ار اي which muscles بس عشان اللي ورا كمان يسمع. لو ممكن اللي ورا يجوا قدام قاعدين ورا ليه؟ يعني اللي عايز يا ولاد يجي الدكاتره بعد اذنكم.
MRI muscle
تعالى يا حبيبي. تعالوا هنا جنبنا. ما تقعدوش ورا عشان تشوفوا معانا الحالات وتسمعونا كويس.
So we have
اول صف هنا تعالوا يا حبيبي. منا. تعالى يا حبيبي. يعني ما تعملوش تكليف كده. تعالى خالد رامي
أحمد.
تعالى احمد طه. يلا يا دكتور اقعدوا قدام كده ويعني عشان تشوفوا الحالات. تعالوا اول صف تاني صف. وبعدين عايزاكم تتناقشوا مع الاساتذه. هم جايين عشان يعلموكم.
So we do have changes on the muscle MRIs, mainly so degenerative changes, mainly in the upper arm, and overall I would say muscles are thin for the age, and that you can't see because of mild adiposity. In the stir signals, stir sequences, the images are not optimal. I would need so higher magnification.
Posterior
Yes,
compartment of posterior compartment of lower
but
limbs.
I am looking at the upper body first and try to see something in the upper arm. There could be something, but the images are sort of too reduced to be to make it clear. And then we go. Okay, so here we have something. Yeah, here we have also edema in the upper arm, mainly in triceps. So something is going on, activity. And then we go to the lower body part, and the pelvic muscles do not look that bad, but when we come below pelvic to the thigh level, there is again minor degenerative changes, mainly in vastus lateralis, and something also apparently in semimembranosus. We will then check on the stir signals, and we do have signal increase in these same regions, but not too heavy. So that is of course related to the relatively mildly elevated CK levels. And when we go to the lower legs, on the T1s, yeah. So for the age, yes. If this would be a 60, 70-year-old patient, it would be within normal range, more or less. But there is in the calf muscles sort of too much of bright material within the muscle tissue, suggestive of some loss of muscle tissue and replacement by fat and connective tissue. And then on the stir sequences, this is the most clear finding with the edema in the same region, the calf muscle.
muscle posterior compartment of the calf. الإديمة دايما بتقول إن في inflammatory changes or metabolic changes. So, and it is very bright here.
This is more metabolic changes do not usually cause degenerative changes on the T1 signals until very late in some cases, and many like myocardial do not cause that usually at all. The stir signals can occur during a sort of acute damage after exercise or something like that with high CK levels. That's okay. But these are not sort of metabolic. The combination of these findings is not metabolic. It is in the range of degenerative myopathies. Also, I would not exclude milder dystrophies. So what could make this pattern more in the mostly in the calf muscles? We have a range of genes, at least 20, 30 that could be compatible with this. So we definitely would need further studies here, including also muscle biopsy. And the family was negative, you said?
There is positive consanguinity only,
ولاد عم.
but no similar condition.
Yes. So the consanguinity, of course, then heavily makes us thinking about the recessive disease, and again, you have a lot of possibilities in that range. And I would not even go to speculate on which would be more likely or less likely. So a muscle biopsy of the calf muscle would be my first choice. Yes.
So, Professor, you put possibility, it's a muscular dystrophy before inflammatory myopathy. He's 5 years old.
Yes. So
5 years old now, and 5 years duration.
3 years.
Steroids and no improvement.
yes. Usually in childhood, if you think of a myositis, the most common type is, of course, dermatomyositis. And that goes with rather high CK levels in the thousands, normally. We have one other type, which is now of high interest, also in the pediatric field. It's the immune-mediated necrotizing myopathy, which could in fact be an alternative. We have 3 forms of that. The one that is known in the pediatric field in the children now is the HMGCR antibody positive variant, which was excluded. Yeah, if I saw right.
Negative, it was negative.
So the other 2 forms, the SRP antibody positive, has not been observed in children, only in adults. Yeah, yeah. And then we have a third, which is also unlikely in this case. We have a third etiology for immune-mediated necrotizing myopathy, and that's a neoplastic condition causing this as a paraneoplastic syndrome. And that's unlikely in his. Yeah. Yes, 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 yes. I would not consider that. So the myositis field is less likely, I would say. I would still consider genetic myopathies and mild forms of dystrophies. We have some milder forms of limb-girdle muscular dystrophies that also could. I mean, what you first think of when looking at this would be maybe dysferlinopathy, but the age is a bit young, and calpainopathy as well could also be in the range, although the upper limb first is unusual for calpainopathy, and you would expect to have some tight heel contractions, and also scapular winging. We will have a look at that. But no clear first choice alternative with this information so far.
Do you want to see the patient? تعالى حبيبي اسمك ايه؟
محمد.
محمد امشي كده يا محمد امشي حبيبي ممكن تقلع الشوز بتاعك؟ عايزاه يقلع الشوز اقلع الشوز والشراب يا حبيبي وارفع ارفعي له ماما البنطلون اللي فوق بعد اذنك.
So when he came up from the chair,
Yes.
he was struggling,
Yes,
moving hands.
he has proximal weakness.
has waddling gait, post-flower sign.
يلا امشي يا حبيبي يلا وري البروفيسور يلا امشي عند ماما. Yes, and there is some deformity of the feet during walking. امشي كده كمان يا حبيبي.
Inward.
يعني الرجلين داخلين لجوه كده شويه وهو ماشي. Inward deviation. روح كده.
Can you
Yes.
can you
امشي على توتير صوابعك زي الاستاذ كده. يلا امشي على توتير صوابعك. يلا تقدر؟ ما تقدرش.
That's the main problem.
Very difficult. طب تقدر تقف على كوبك؟ Yes. He cannot do tiptoe because of the calf muscles, but can do here. Yeah.
So now we would like to see the
No winging of scapula. Can ماشي ممكن
تعالي يا ماما. وريني ظهره بعد اذنك.
no clear
no ممكن نزقها على الحيطة يا محمد زي ما عملنا قبل كده.
زق ايدي زق.
No winging of scapula.
خد ايديك الاثنين كده يا حبيبي. افرد ايديك يلا.
Okay, so with some difficulties, no peculiarities of hyperlordosis or things like that. Okay.
Good, good.
That's fine. No problem.
افرد ايدك يا بابا. امسك الاستاذ يلا امسك جامد. شاطر شاطر.
Not the normal.
يلا صوابعك لفوق صوابعك لفوق لفوق لفوق. اوكي.
Okay. Good. What do we like to see more? There is no
You can see if there is gower sign.
contractures.
بس هو دايما بيمشي على طراطيف صوابعه ولا ما بتحصلش؟ لا ما يقدرش. تمام تقدر تقعد على الارض وتقوم؟ يلا قوم يا حبيبي اقعد على الارض وقوم يا بابا يلا اقعد على الارض وقوم. I'm sorry. No. خلاص بلاش. He cannot when he said he cannot go up so sure. I think the lower limb is more than the upper limb. I think so.
We believe there is considerable proximal lower.
اقعد على الكرسي يا حبيبي.
So
بس خدت بالك من الديفيشن ده؟ الديفيشن ده برضو. واحنا ممكن حد يبقى يجيب لنا من بره لو عندهم كحول او جل؟ ها؟ ايه ما هي نورهان راحت. نعم. سوري يا حبيبي.
In the upper limb, distal weakness is more obvious than the lower limbs.
Both.
Both-
لا proximal is severe.
Proximal is severe,
proximal
but
is
distal
severe.
weakness is more obvious in the upper limb than in lower limbs.
هتعبك تاني، هات لنا كلينكس بعد اذنك. هو بيحب يغسل
You will
ايده.
wash it.
He likes to wash the hands. I'm sorry.
Hard, nothing?
High arch.
No high
Can
arch
you
palate,
see?
no high arch foot. افتح بقك للآخر كده.
شكرا حبيبتي، ربنا يخليك يا رب. خسرناكي والله. So I think
Is it progressive? Is it getting worse over time, or is it static? Is it progressive weakness? or-
Sarah,
Progressively, gradual onset,
progressive.
progressive course.
Progressive.
Although he was on corticosteroids for almost 2 years, we stopped it because of the side effects and the cushingoid fascias and the central obesity.
I think the critical investigation will be a muscle biopsy.
muscle biopsy.
Yeah, that's
Yes, from calf muscles.
not necessarily. I think he's general weak. Calf maybe. You don't want to biopsy a muscle which is end stage disease. You want to pick up a muscle which has got a calf would be end stage. I would suggest probably a muscle which is less involved. So you can but calf is quite advanced. So
Yes, calf is markedly affected. Yes, with
so you
fatty
might just find
infiltration.
fibrosis there and whatever. So I would probably less weaker muscle, probably a deltoid.
Okay.
I would say there is very much enough good muscle tissue. I would go because there is
Okay, Professor will do the biopsy. Okay. I would like to say a word here because
the problem with muscle biopsy is when you have a totally white muscle on T1 sequences, totally replaced, then you should not go there. But as soon as you see some muscle tissue, it's fine, because you wish to have also affected muscle tissue to be able to see something of interest. You don't want to go into a normal muscle. And in dystrophies, you can have very
Because if
high
we-
variation.
if we go to the biceps or the tibialis anterior, we may miss a pathology. Okay. So muscle biopsy first, then we will do the genetics radwa to know.
So, in fact, I would do both at the same time, because you can't get to the final diagnosis with your muscle
Yes.
biopsy anyway.
But because in Egypt we still have a problem in interpretation of genetics, so I prefer first to reach a diagnosis before the genetics. We
And-
still have a
yeah,
problem
okay.
in genetics.
Yeah,
So sometimes I want to know what is going on before genetics. Professor Ayman Nasif, he's professor of neurology. He's my colleague, dear colleague. He will share us today to talk about the congenital myasthenic syndromes. Dr. Ayman, you know, of course, Professor Bjarne Odd from Finland, and our dear professor for the first time in Egypt, but not the last time, please. Professor Zaim Siddiqui, an eminent professor in Alberta University, Canada. Thank you. Okay, Sarah, تهيألي this is
Doctor,
enough.
he made neuromuscular panel. I want to demonstrate this. Genetic
is
studying.
this?
He made MELPA for Duchenne, but it was negative.
Duchenne, he is not Duchenne.
Yes, and this is another one. The neuromuscular panel يا دكتور غير الدوشان.
Is it whole exome or neuromuscular panel?
Neurovascular panel.
Okay, because we have a famous 50 genes of limb-girdle muscular dystrophy,
Yes.
dystrophin, and some of metabolic myopathies, but it doesn't show anything. It is in centogene, and that's why we have to do the muscle biopsy first. And we have to do it from the calf muscle. لا لا هو شايف ان الكاف المين باثولوجي فيها بس مش ماركتلي افكتد، فهو بيقول ان في حوالي 20 types of muscular dystrophies بيعملوا المنظر ده، فقال انا لازم اخد منها هي.
Do we have the list of genes included in that panel? Here, yes, okay.
No, it is more than 50.
Yeah. Yeah, but there are not even all limb girdle known genes. I just see directly that there are some missing also among those later identified.
محمد عادل عبد الحليم.
Yeah. This could also in the sort of continuing efforts be a possibility for a collaboration. To
You want to take?
check. We can discuss that at least. Yeah. Mm.
So our differential diagnosis, Dr. Nagia, Professor Odd.
Professor Odd found that it would be.
I would consider based on the clinical phenotype and MRIs. I would say this is a limb girdle type of
Limb girdle.
muscle disease. Yes.
Be
The CK levels are not that high as we usually see with childhood onset limb girdles, but there are alternatives also for that.
Thank you.
Thank you, Professor. I must mention that Professor Oud, with his visit in Egypt 2016, he gave us the protocol of MRI muscles. And since that time, 2017, we started as a first university hospital, whole body MRI muscles in Egypt. Then another hospital, then most of the hospitals that are doing now the MRI muscles. So thank you, Professor. Third case, Dr. Nurhan. Dr. Nurhan Bilal will be our next assistant lecturer of neurology. Will present the third case.
Sorry. My clinical case presentation, Mrs. N.A., is a 40 years old female patient, married with 3 offspring. The youngest, 7 years old, used to work as a social worker, but left work 2 years ago due to her current illness. Lives in Al Mansoura, right-handed, with no special habit of medical importance, regular menses. Complaint of the patient, bilateral upper and lower limb weakness. As regard family history, patient has positive family history of diabetes complicated with peripheral neuropathy in her aunt. No family history of consanguinity, no family history of similar condition, no family history of other neuropsychiatric illnesses. As regard past history, irrelevant past history. As regard history present illness, the condition started of gradual onset progressive course of 2 years duration when the patient started to develop right lower limb distal weakness that was associated with atrophy and was severe to that the patient was limping. 2 months later, patient developed right foot drop. So patient sought medical advice and diagnosed as immune-mediated peripheral neuropathy. 10 months later, patient developed left lower limb distal weakness associated with atrophy and muscle cramps in calf muscles. And it was severe that the patient became bilaterally supported. 4 months later, patient developed bilateral lower limb proximal weakness associated with atrophy and fasciculation in quadriceps. It was severe that the patient couldn't climb stairs, then became wheelchair bound. 2 months later, patient developed bilateral upper limb distal weakness associated with atrophy, and it was severe that the patient couldn't hold the objects. Also, patient complained of fasciculation
in paraspinal muscle and the loss of weight up to 10 kilogram within 2 months in the beginning of her condition. All through the history, no other motor symptoms, no sensory, no sphincteric, no bulbar symptoms, no respiratory muscle affection, no neck muscle affection, no behavioral or cognitive disturbance. As regard the general examination, came negative or no abnormality detected. As regard neurological examination, patient is conscious, alert, oriented, concentrated, with intact memory. MoCA scale came 30/30. Speech, no dysarthria, no dysphasia. As regard the cranial nerve, no cranial nerve affection. As regard motor examination, state, generalized twisting with atrophy of senar hyposenar muscles in both hands, and thigh muscle with anterior and posterior compartment of legs, more on right. Fasciculation seen and felt in deltoid and quadriceps muscles in both lower limbs. Tone, decreased tone around the ankle, bilateral, and the knee, especially on the right. As regard the power, bilateral upper limb distal weakness, bilateral lower limb proximal and distal weakness, proximal more than distal, more on right. As regard reflexes, superficial reflexes, bilateral flexor plantar, deep reflexes, upper limb, brisk all over, lower limb, preserved, left knee and lost knee, right knee and both ankles. As regard coordination, intact in both upper limbs and couldn't be assessed in lower limbs. Gait couldn't be assessed. As regard sensory examination, intact, superficial, deep and cortical. No stretch sign, no frontal release sign, and spine intact. As regard investigation, labs, CK total came 430. Nerve conduction and EMG study was done first, showed evidence of proximal neurogenic pathology at the level of anterior horn cell, affecting the lumbosacral region with mild affection, the rest of region examined. Second, nerve conduction and EMG was done, finding left peroneal and left tibial distal motor latency was normal, as regard amplitude was decreased, and normal velocity. Needle EMG of left leg and right arm showed abnormal spontaneous activity in form of fasciculation and fibrillation potentials in tibialis anterior muscle. Motor unit action potentials are polyphasic and large in tibialis anterior, and there are few motor unit action potentials with short duration, mean duration in most all muscles. MRI brain was done, came no abnormality, with no abnormality. MRI of the lumbosacral plexus and the sciatic nerve on high field MRI was unremarkable. MRI of whole body for muscle came bilateral asymmetrical muscle affection of both lower limb being more prominent on the right lower limb, showing more subvolemia and more myoedema compared to the left side. I have it. Arba'in, 40 years. 2 years duration.
Still progressing?
Progressing, yes. 2 months ago, she developed bilateral upper limb distal weakness.
I mean, this is a clear case of ALS.
It's motor neuron disease. I won't call it ALS, but motor neuron disease, for sure. I don't think imaging or brain MRI was required in this case. It's a low motor neuron disease with neurogenic features, fasciculations, asymmetric onset. It's a
Yes,
so,
in
it's,
upper limb.
I think it's a motor neuron disease case. Can't think of any peripheral neuropathy, whatever. It's pure motor syndrome with obvious manifestations of that. So it's motor neuron disease, I would say.
Yes, but when we did a genetic study, whole exome sequencing, Negative for amyotrophic lateral sclerosis, but positive result for Emery-Dreifuss muscular dystrophy by genetic dismutation or mutation in gene SYNE1. Another?
What do you
Okay.
which gene?
Which gene? Okay, so we sent another genetic study for Synto gene, came negative for superoxide dismutase 1 and positive for SYNE1.
I'm now confused. What was the gene identified for Emery-Dreifuss?
Yes.
سنتوجين ولا
Two, both of them, Synto gene and another one.
يعني مركز البحوث.
مركز البحوث.
National Research Center and Syntogene
Okay.
shows the same gene
Yes,
that of Emery-Dreifuss.
yes, yes.
Heterozygous or
Ah.
homozygous?
Heterozygous.
Hetero.
Forget it.
Heterozygous.
Forget it. Thank you, because this was my opinion. That's why we have genetic study.
By the fact, would not even prefer Centogene anymore.
What we'll do.
Yeah, that's another issue. But they now report SYNE1 gene. And unfortunately, in also good medical journals, there are lots of false publications. And SYNE1 is one of these, where there are several reports indicating this gene should be responsible for Emery-Dreifuss type muscular dystrophy, but it's totally obscured the whole field. So, yeah.
See, you've got so many other evidence pointing. You got a muscle biopsy done, isn't it? You had a biopsy findings. So you've got a number of findings of a neuropathic process going on. So whenever you find a test like that, you got to go back and see whether it's fitting the clinical picture or not. It is a, and if you're in doubt, they are talking about a muscle disease, and you've got a motor neuron disease. You can do a small piece of muscle, and you know it right there and then is myopathic. But I won't even do that. It's a simple case of motor neuron disease. But if you still have doubt about this, you can do a muscle biopsy.
No, I think the evidence is clear to me. The rapid progression. Which disease makes that rapid progression with muscular wasting and heavy activity on EMG? It's very obvious to me. And if you go to ALS genetics, as you know in the textbooks, ALS is stated as a mainly non-genetic disease, but the thing is more complicated. The thing is more complicated. In Finland, we have already 1 out of 3 having a defined genetic cause for their ALS. And there are 2 main genes responsible for that, which have an increased frequency in Finland. The C9orf repeat expansion, and then SOD1 homozygosity. In other countries, these do not account for that number of ALS, but when you look at the gene list associated with ALS, you end up with almost 50 genes, each of them contributing very low to the total number of ALS cases. But what it means to me, with our experience in Finland, then 1 out of 3 already have a known genetic disease cause for their ALS, means that it is just more complex than monogenic. So, and we have indications of oligogenic mechanism. So if you have a number of variants in these 50 genes, the total sum may be enough to cause the disease. This is still ongoing research and has to be confirmed, but that's the current sort of feeling in the field.
Can I ask about the age of onset of ALS in Finland?
So normally both SOD1 and C9orf are quite late onset, but we have one family with FUS1, which causes a juvenile ALS. So there are different forms that can. Did you okay?
Because in Egypt we found that the early onset, that before 40 years, and the juvenile onset before 20 or 25 years, representing about 50% of our patients.
Oh,
That's why
yes.
we started a project
Yes.
3 or 4 years ago with Ulm University about genetic study. We found some families with SOD1. The youngest was a boy 10 years old, and he has
Yes.
a typical classic ALS. And we have other, Rado will present some of these cases next Thursday. We have, we didn't found C9orf till now, but we found one family with FUS and many families, I think, with SOD1.
Yes. So yes, we have the mild SOD1 variant in homozygosity, which causes the late
We
onset.
have homozygous
Yes,
families also.
but there are also quite
Dominant?
more severe dominant forms.
Yes.
The question we have now, which is very important to us, about the conflicting results with the genetic results and the clinical data, because we start to encounter this very often when the clinical data is suggesting a certain disease and the genetic come in a very different direction.
Yeah.
So do you suggest that we discard the genetic data if
Yeah,
it's
yeah.
not fitting?
Yeah. So for this, I will tell more in the conference on Wednesday about diagnostic problems, current diagnostic problems, which includes the high throughput sequencing now, exomes and genomes used widely for diagnostics, which exactly create this situation. What to do? Who is going to tell what the variant means?
The clinician.
Just the
Yes.
geneticist
Must
doing
be
the
interpreted.
checking just the sort of publications on these genes and reporting according to that, or should there be something other? So we are working in our center in a very strict way. The geneticists are providing a list of variants which could be of interest. And that is usually a list of 20, 30 variants. And then, of course, related to frequencies and all such stuff, and published data. But then this list is sent to 3 clinicians for sort of checking what could be compatible with the phenotype and what is not. And then that feedback is going back to the geneticist, who is then writing the final report. And that is, of course, a complicated way to do it, but then you avoid this type of issues. So for the MRIs on this lady, hundreds of images, I try to pick up one series of still sequences on the lower parts of the limbs to see. I think there was some indication of increase edema increase.
Edema, yes.
Yes, yeah,
Subbulimia and
yeah.
myoedema.
So there are no dystrophic changes as expected. That's clear. And then you have some signal increase on the stir sequences. And I will explain that in my lecture in a short minute. But yes, I see it. So we can see mainly in medial gastrocnemius muscle,
Yes.
there is a signal increase. And that is compatible with ongoing neurogenic damage.
Research for paramalignant disease?
No.
How common you find cases of ALS associated with malignancy or paramalignancy?
I can't even remember any one.
Usually we search and we can't find.
I can't remember any. And of course, if you consider the frequency of malignancy in the population, you expect to have one coincidental patient now and then.
Yes, okay.
Yes. Because this was a conflict. They diagnosed her Emily Dreyfus. Yes, and she's clinically ALS. And it was with our behavioral. She said, it's a dystrophy. No, she's not a dystrophy.
And of course, you have been afraid of that disease. That's for sure. Now, of course, the next step is to see if we can find the real cause. Now it's all can be done.
ممكن يبقى حاجة تانية. لا وستيل يعني هو بيقول this is still a search. بس مش Emily Dreyfus. مش Emily Dreyfus ده أسوأ. Emily Dreyfus ده أسوأ. ها؟ استني خليه يكشف عليك.
The clinician would have had the report of the hemorrhagitis. They would have said, no, there is no contracture. So, hemorrhagitis is kind of variable, usually childhood.
لا ما بيستعملش جوانتين. بإيده بيغسل إيده. إحنا بس خليهم يبصوا عليك بعد إذنك يا أسماء.
We have a video.
What is the question? Okay. هو بس بيشوف حاجة كده.
She has more momentum.
Of course, he is actually already so advanced that you
There was pains and this decreased now. مش كده؟
Yes.
كان كرانس ولا كانت آلام؟
Grams can.
كرانس. Yes. الستيل الفاسيكوليشن.
Yes, increased. Increased.
والmovements ما تحسنش. يعني she took some sort of immunotherapy and it is not improving. And sometimes they said we can give a trial of plasmapheresis, sessions of plasmapheresis, give a trial of intravenous immunoglobulins, any endoxan even, but this,
I mean, if you are uncertain,
yes.
but in
She has video for fasciculation quadriceps muscle.
She said that her fasciculation looks coarse, shock-like or coarse contractions. She was thinking this could not be a fasciculation, maybe another abnormal movements.
More massive.
Mm.
Yeah, but yes.
Mm.
Asymmetrical. Right affected more than left.
Normally they are a little bit smaller, but you can have this more massive. Think of that. Yeah.
Moving a small muscle.
Yes.
يعني بتيجي في السمول muscle
It's
of
okay.
hands, it can move
Yeah.
small joints and fingers. فهي بتقول ان هي بتيجي كده وبتقول ان هي coarse shock like. طبعا عشان هي بتقرا كتير فكانت يعني comparing this with ALS and she thinks that this is not atypical of ALS.
انت هنا صح؟ جيلك هنا وظهرك ظهرك. No many, yes. Yes, by examination, no many, yes.
And of course, the C9orf variant usually showing bulbar effects at the same time when the limbs are this weak and atrophic. So I would not consider that as a likelihood. C9orf would not be likely, I would say. Yes, I mean you have to, if you have a unclear situation and a young patient with a suspect motor neuron disease, ALS, you should do whatever you can. And then, of course, it's more clear to everybody, also to the patient, when we have a clear cause, a final diagnosis, then everybody knows, and the uncertainty at least is not bothering you in the same way.
So we go for muscle biopsy and no?
No, I would not.
What's your opinion about
Riluzole? Yes. So in most neurological departments, they are regularly prescribing Riluzole for ALS patients. But as you know, also the sort of published effects are extension of lifetime, life expectancy with 2-3 months. So, and you can see in many cases when you start the medication, even increased weakness. So my personal opinion is, I know the general opinion, but my personal opinion is that the benefits are extremely limited, if any, and I do offer my patients a prescription, but I do not sort of say this will help you.
Neuron.
There was
What
a
about-
clinical trial
Yes.
of stem cell therapy. for
Yes,
neuron-
yes, yes, yeah,
neuron
I
in
know,
the
yeah,
States, yes.
yeah,
Yes.
yeah. And you can still have stem cell therapy is, I think, even in Ukraine, not maybe now, and in China. There are many private clinics offering that, but there is no sort of confirmation of any use.
And Darafone also
Darafone,
Darafone.
the new one,
Yes.
the neuroprotector.
Yes.
Also we didn't found it.
No. Yeah.
I have 30 ampoules Darafone.
She said she has a Darafone, but
Yeah.
no benefit.
Yeah.
You didn't take.
Yeah.
هو نفسه مصدر شركة ولا شركة. بس نيورون not approved, not FDA approved. لا
Darafone approved.
there is not approved. There is a drug, I don't remember اللي هو ال AMS. They asked it to be approved. يعني some أنا متابعة. Neurologists asked FDA to approve it to decrease deterioration, but not approved yet. But not approved yet. It will be approved, don't worry.
What's your opinion regarding Darafone?
Regarding,
Darafone.
Radioclava.
I mean, they are all in the same range. Everybody wishes to have some sort of therapy that works for the disease. So there is high interest, and everybody is eager to find something. But at least so far, riluzole is the only one which has been shown in decent studies to have some effect, even if my own personal conviction is that it is very marginal. If no, so I told you, I tell the patients this is now used in many clinics, and I also am willing to prescribe you riluzole, but my personal opinion is not in favor.
Thanks, sir.
بصي خبر كويس. هو حاجة اسمها AMX 0035 اللي وصوا National Peripheral Central Nervous Drug Advisory Committee asked the FDA to approve this. إن هو قلل الديتيريشن. هيوافقوا عليه بإذن الله. إن شاء الله نطمن عليك، ما تقلقيش. شكرا يا حبيبة قلبي، شكرا. إن شاء الله نطمن عليك، ما تخافيش.
Thank you.
We have many juvenile onset and yes, and early onset, and we are searching what is the cause of this. Maybe toxins, maybe insecticides, many chemicals in the food, many causes for degeneration of anterior horn cells.
Unfortunately, we found many physicians prescribing IVIG for general cases
Yes,
like
immunoglobulin,
But
immunoglobulin.
it's not approved.
See,
Waste of money.
when you have the patient in the clinic and you see the progression of the disease and more or less desperate situation, you tend to try to do something.
I think insurance is not approved this for patient like that.
No, I mean, in our hospitals, you have a wide range of independency to decide what medication should be offered. So you can always sort of indicate, yes, it looks like ALS, but we cannot exclude immune-mediated disorder, and we then decide to try.
another case? Riham? Okay, our dear colleague, Dr. Riham Mahfouz, Assistant Lecturer of Neurology Department, will share us with another case.
Okay. Good morning, dear professors. Okay. Okay. Our patient, OMA, 59-year-old male, married with one offspring, right-handed, works as a driver, smoker, 1 pack per day. Complained by lateral lower limb weakness. With irrelevant family history and past history of diabetes for 15 years on insulin, not compliant, not controlled, complicated by retinopathy, cataract, and diabetic ulcers. The condition started 2 years ago when the patient started to develop bilateral pill rolling tremors in both hands and face with no account on bradykinesia or rigidity. 6 months later, patient started to develop rapid onset stationary course of left lower limb distal more than proximal weakness. 1 week later, patient started to develop hypothesia and sense of pins and needles on the same limb up to the knee. Few days later, he developed left upper limb weakness, distal more than proximal, followed by hypothesia and sense of pins and needles to the elbow. Patient developed the same clinical picture with the same course on the right side of the body. So he developed weakness and hypothesia of peripheral nerve distribution on the left side of the body, followed by the right side of the body. Patient's examination. Patient is vitally stable. He has generalized muscle weakness with normal affect. Bilateral lower limb and upper limb edema up to the knee and up to the abdominal wall with skin lesions on both legs. Neurological examination, conscious, alert oriented, no dysarthria and dysphasia, cranial nerves, all intact. Motor examination, patient has atrophy both distal and proximal with guttering and atrophy of thenar and hypothenar muscles with distribution of weakness, proximal more than distal. In the upper limbs and lower limbs could not be assessed due to ulcers with normal tone. Deep tendon reflexes are lost all over. He has bilateral upper limb tremors with high glove and stocking hypothesia with sensory level at C2. Okay. These are the tremors. During rest, he has more of a pill rolling form of tremors also in the face, but during this examination, he claims they were improved and they were not seen, but they were seen before this video.
Biceps after Riham.
البايسبس كنت اكتر يا دكتور.
I found his face like a mask face.
It was reactive. It was
Not
reactive.
atrophy proximal.
Exactly.
Severe atrophy.
He had severe atrophy, both proximal and distal.
But no fasciculation.
No fasciculation. With extensive hypothesia.
Sorry?
Hypothesia.
Hypothesia.
Yes.
Diabetic.
Yes, severely diabetic, uncontrolled.
Diabetes for how many years? Diabetes?
15 years. 15 years.
15 years. And
Yes.
this condition duration?
2 years.
2 years.
Yes.
Yes.
Yes. The patient also gave a query history of chronic constipation, which was investigated and suspected for malignancy, but nothing came up.
الجيت بتاعه ايه؟
Cannot be assessed. The patient wheelchair bound. Wheelchair bound. Yes. Also, he have extensive pains in his lower limbs due to the infections, so his lower limbs cannot be properly assessed.
Fungal infection,
Bacterial.
bacterial.
Ulcers in both legs.
Where is the ulcer? Distal?
Yes, distal and this knee one, yes.
So he's uncontrolled diabetes.
Exactly.
What about the renal function? It's okay?
We'll shift to the labs later, but they were fine.
So السبب الترمر started by tremor started by tremor
أول حاجة بدأت الtremors.
First started with it, but the tremors is not just rolling. There's
Yes, they're postural.
posture and
It could be neuropathic tremors.
it could be neuropathic tremors. Scores كمان.
Oh,
الترمرز ابتدت قبل الويكنس وقبل الاتروفي
exactly.
ممكن زادت عليها نيوروباثيك ترمرز بس ابتدت بالرولينج.
He has no bradykinesia or rigidity, and his affect is very
Posture
reactive.
كمان يعني rolling posture كمان. Yes, to movement
metabolic
Joint positions.
Excuse me?
Joint positions.
They're normal.
No? How do you get a neuropathic tremor in a normal joint position?
Sorry, normal joint. Affected. Yes, yes, affected.
vibration.
Affected.
Vibration.
Yes, affected. Sorry,
Position said must be affected.
affected. Sorry.
قالوا 3 4 بجيبكم بقى.
metabolic functions كويسه
نعم.
metabolic functions كويسه renal وليفر
لا normal.
عشان انا فكرت ان هي تكون metabolic.
So we wish to know what about the spinal fluid?
CSF.
Elevated proteins, 78, but 78 is not considered very significant if he's uncontrolled diabetic.
But it is high.
Yes.
Because the normal is up to 42.
42, but he's above 50 and he's uncontrolled diabetic, so it has to be above 100, yes. Yes.
Yes, please. واحنا يعني ماشيين
These
بقى
are the
كده
skin lesions. Excuse me.
Sorry. Any constitutional symptoms like weight loss and stuff like that?
Yes, he has weight loss.
How much?
Significant weight loss. Around 10, 20 kilos.
10, 20 kilos?
Yes.
With that high degree of atrophy.
Yes.
He has lost muscle at least 10, 20 kilograms.
He has significant skin lesions and ulcerations. His nerve conduction and
sorry, this ulceration or skin lesion that
Diabetics.
of dermatomyositis
Nope.
or not
No.
typical?
no, no.
Not typical.
Nerve conduction showed axonal, sensory and motor polyneuropathy, polyradicular neuropathy. PAN-CT with contrast.
My apologies. Was it symmetric or asymmetric? To
The
this-
weakness?
No, the nerve conductions.
Neurophysiology.
Was it symmetric or asymmetric? That's
I
very
can
important.
check the numbers, but I think they were symmetric.
Did it do it one side or both sides?
Both sides. Okay.
Sorry. So
we
it is
have-
important to look at whether it's symmetric or
Yes,
asymmetric.
it was symmetric. Or
What are the velocities?
the velocities. في حاجات مش باينة في الطباعة. Lower limb nerves were
Not detected.
not detected. But there was significant edema as well.
It looks a severe form of axonal neuropathy.
Exactly.
But how can you state axonal if you don't know the nerve conduction?
That's right. This patient,
That-
it'll be good to do some proximal studies.
Mm.
But anyway, yeah, it's important.
Excuse me.
الميديان الكوندكشن فيلوسيتي كويسه ولا مش
ما انا بحاول اطلع انا مش قادره اشوف بصراحه. conduction velocity. مش عارفه اعمل زوم.
What about the EMG يا ريهام?
He did not do EMG.
Sorry?
He did not do
No.
EMG.
No EMG.
No EMG.
No EMG.
Yes.
What's your opinion, Professor? They are doing nerve conduction and no EMG in such patient with proximal weakness and atrophy.
Yeah, I think.
He
yeah.
has.
So in this patient, if it would come to me, because naturally he's got diabetes, it's a tough patient to have to do more extensive studies, bilateral, proximal studies. I haven't even do facial to see if there's any prolonged distal latency because, so it's hard to say it's axonal without having more detailed studies.
Yeah.
Yeah, it's hard to pick up. So it is a limited study.
To me, just the rapid progression and the way it looks like, I would think this is some sort of CIDP. That would be my first.
Or I looked at his fingers, he's a heavy smoker. I looked at his fingers all brown with cigarettes. I looked at the exam.
Yes.
I would do a PET scan on him before I jump into CIDP. If you do have PET scan over here,
We
I'll
do.
make sure
We
that you get a
did.
PET
We
scan.
already did a pan CT with contrast, but we didn't do a PET scan. But his pan CT was insignificant.
But PET also will give
Okay.
us more
A better.
detail.
Yes,
Okay.
yes, yeah.
I found it is a common that to find immune-mediated neuropathy with uncontrolled
Sorry.
diabetes mellitus.
Sorry, one more question. I would do a nerve biopsy, although it's advanced diabetes, but it's limited because the nerve conducts are limited. I might not do a sural. I might pick up another nerve, which is less affected. But nerve biopsy sometimes can give you inflammatory changes in diabetes. So it's a tough study, but you have to find ways to. Those small ulcers may be nerve infarcts. So vasculitis is a possibility over here. Those small ulcers you're seeing in the skin can be a vasculitic process. So I'll make sure that I've ruled out all vasculitic causes as well.
Okay, we can do nerve biopsy, sural, and electron microscopy.
Yeah.
Not sural.
I'm thinking sural will be, I know, yeah, definitely the PTMG with more. See if sometimes we can do sometimes we do a nerve and muscle biopsy to look for vasculitic process.
Which
So,
nerve you prefer to take?
so for him, you said sural is fine, but superficial peroneal can be taken out as well with a muscle. Because sometimes to find out vasculitic change, seems to me the picture was mononeuritis multiplex, where it was picking up individual nerves. So I will bend backwards to make sure if there is no underlying vasculitic or another cause for this mononeuritis multiplex. Although diabetes can present like that, but there are other causes. And the rapid progression, the professor said, I would look for those causes.
I will even go for therapy
Yes.
at the same time as.
What
for-
therapy?
I would probably try one of the three first, and if no use, I would try the other three. So we have the IVIG, we have the conventional steroids, and we have the plasmapheresis.
What you did for him?
Unfortunately, we were a bit worried regarding his general condition, the edema, and the uncontrolled diabetes. So we preferred to skip the steroids, and we're planning for IVIG.
You started IVIG or
We're,
not yet?
Plan-
we're on the route.
planning.
Yes.
But you did for him plasmapheresis or not?
No.
No also.
Yes. His general condition was a
His
bit worrisome.
Renal function, Dr. Ayman was asking.
Yes, it's fine.
Renal, hepatic, everything is okay.
Yes.
Electrolytes, everything is okay.
As far as I remember, yes, there was no abnormalities in his labs except for one of the tumor markers, which was very mildly elevated, considered non-significant. And
So I think
his
also
hemoglobin was dropped.
PET scan is very important.
Okay.
See, I have to go for the diagnosis first before I do all those things. IVIG is notoriously addictive. Patients feel a psychological benefit out of it, and you'll be stuck. So I will
Same with
first
steroids.
same as steroids. So I would go for the diagnosis first. I think before I embark on any treatment, because then otherwise you put him on a lifetime of IVIG without knowing what you're treating. So that would be my approach.
If he would stand up walking after a treatment, you would have.
Thank you, dear professors.
Good morning, dear professors and colleagues. I am Asma Helmi, Assistant Lecturer of Neurology at Shams University. I would like to present the next case. Personal history, Mrs. R.S., 32 years old female patient, divorced with 2 offsprings, youngest is 5 years old, lives in Al-Matariyah, right-handed with no special habits of medical importance. Regarding complaint of the patient, bilateral lower limb weakness. Regarding her family history, non-consanguineous marriage, she has query history in her elder sister. She had query autoimmune disease. She is on methotrexate, yet we didn't know what is the disease. Past history irrelevant. History of present illness, gradual onset, progressive course of 2 years duration. The condition started 2 years ago when the patient developed left lower limb weakness, distal more than proximal, associated with fasciculations in the thigh, with atrophy of foot muscles and hypotonia around knee and ankle joints with left foot drop. She also reported she had feel some cramps. 8 months later, she experienced the same weakness in the right lower limb with the same distribution, yet it was less severe than left side. Also, it was associated with hypotonia around knee and ankle joints and affected the patient to the degree that she couldn't walk unless supported from one side. Moreover, patient reported fasciculations in paraspinal muscles, was seen by her neighbor as she is taking care of her. Patient also reported sense of pins and needles in her lower limbs, distal more than proximal, and was on left side. She reported that it was transient, very short duration, and improved spontaneously, and didn't account again on it on further asking. 4 months later, she experienced left upper limb weakness, distal more than proximal, with atrophy of thinner muscles, yet with no change in tone and no fasciculations. All through history, there is no sensory manifestations, no other motor, no cranial nerve affection, no bulbar, no cerebellar, no sphincteric affection, no fits or disturbed conscious level. A general examination was no abnormality detected. Regarding neurological examination, speech, no abnormality. Cranial nerve examination, she had only end gaze nystagmus, otherwise no abnormality. Regarding motor examination, she had left upper limb mild thinner atrophy, bilateral lower limb mild atrophy of small muscles of foot, with foot drop more on left side. No fasciculations at time of examination, either spontaneous or by tapping. Tone, she had bilateral lower limb hypotonia, more on left side, around knee and ankle joints, yet there was no hypotonia in upper limbs. Regarding power, she had left upper limb weakness, distal more than proximal, flexors equal to extensors. Bilateral lower limb weakness, left was distal more than proximal, flexors of knee and hip more than extensors. Right lower limb distal equal to proximal, flexors of knee and hip more than extensors. Deep tendon reflexes, brisk bilateral, biceps, triceps, brachioradialis, and knee. She had lost ankle bilateral, ankle reflex bilateral. Superficial reflexes, plantar no response due to weakness. sensory examination, intact superficial sensory, vibration, intact sense of position and sense of movement. I already have the patient outside. كم؟ طيب okay. She has left upper limb distal weakness. 32 years old.
Duration 2 years.
2 years duration.
Many young patients.
On left side, in distal, mild weakness. Right side, no.
How's the finger flexor reflex on that side? Finger flexor reflex. You check the finger flexor
Yes.
reflex.
Reflex?
Finger reflex.
Oh, no.
Finger
Finger
gel.
I didn't check it.
Yes عشان هايبرفلكس. نورهان ممكن تخلي الحالة تخش. عبد الله ممكن تخلي الحالة تدخل.
She's got a full drop.
Foot drop, yes. More on left side.
Does she have extension fatigue both weakness?
Yes, yeah, both. Grade 0, no movement.
Ankle jerk?
Ankle jerk, close bilateral, yet other reflexes brisk all over.
The reason I was asking this was because if you find a low motor and an upper motor neuron finding in the same limb, it is very suggestive. So if she had a weak grip strength and a finger flexor reflex is brisk, that tells you a lot. So you can make the diagnosis very quickly there.
كرسي العيانة بس. لا نجيب لها كرسي هنا بعدين. يعني هو هيجيب لك. تعالي يا حبيبتي.
Diabetic asthma.
No, not diabetic.
Yes. Yes. Yeah, she's afraid that she will. تعالي. Okay.
And even better, big chair with
هتقعدي على ده معلش الأول. يلا. You want to see him?
you should have a chair for neuromuscular patients. So elevated chair and with the hands raised on the side. Yes.
Professor Zain, do you want to see her? Do you like to have gloves?
عايز تشوف الفندق
Yes,
ده.
for ايه؟
عايز تشوف الفندق ده.
عشان finger. Sorry, عشان ما أنسى. You want to see the finger here? Just foot drop طبعا. عشان ما يتقل.
You can already see when she takes off her socks. She doesn't do as you do. She has to grab the sock with all fingers.
Okay, I will cross it. If you like gloves, it's okay. الايدين ضعفانين. This left side one. لكن دي ضعيفة عندي. Yes, this is weaker. This is okay.
So what I see over here is she got a significant action of the hand. The front of and this side. The flattening of the thenar and hypothenar muscles are right there. And it's asymmetric, obviously. She may have a little weakness of the extensor compartment as well. And you feel good? No numbness?
Yes, she's
Good.
feeling good.
So pure motor weakness in a brief history.
This
Okay.
is asymmetric.
Asymmetric, of
Yes,
course, I showed them.
This is asymmetric.
And what I was asking was, can I find the hammer? So what you do is, just close my finger, just ask a little bit. So what you do is, you check the finger flex and look at the thumb. It's pretty brisk. You see that? This is called a finger flexor reflex. C8T1, okay?
Finger jerk.
Finger jerk. and this is pretty brisk as well. With that degree of atrophy,
tonic atrophy. There's atrophy
and I
and
can show you the finger flexor. The
Hoffman.
Hoffman will be positive as well on this side. And so let go, just drop it, let loose. And so that's what I was saying. If you find a low motor and upper motor now finding the same myotome, that is very, very suggestive. I would definitely,
tonic atrophy.
I'll definitely scan a spine just to make sure that there's nothing but the cervical spine.
Means both upper and lower limb, lower motor
segment.
neuron.
Yes. So
That's
muscle
very, very
memory.
suggestive. Yeah. I don't need to, I won't push you.
No, it's the same thing.
Mostly depends on ankle.
I can check it.
I used to use it this
If it's
way.
at altitude, I can. But I can show me the hammer. And very floppy foot. Very
Yes.
floppy foot. The
Flop.
tone is.
We have this form in Egypt, especially young generation. They drop feet bilateral, then upwards.
But that also mostly depends on ankle.
Yes,
Yeah.
Maybe not
Sorry.
It's only associated with the
So
rest.
absent.
With the
maybe,
severe-
but we have like this severe arterial cell
But
affection.
with the severe
Yeah.
atrophy, of course, you will lose reflexes in the ankle and also the Babinski. So the upper limb.
Next time you go to get me a better hammer.
A better hammer. It's a bad hammer. في معاه hammer كويسة فضحتوه.
Should be yes.
You realize it?
You are doing MRI right, left, and center, guys. That's 100,000 in.
In fact, I think this is a Babinski hammer.
You prefer that triangle
What
one?
about this?
It's not good.
Yes.
This is for
No.
neuromuscular
No,
conference.
it's a bad
No,
one.
no. Should be a bigger
Bigger one.
one.
No other no.
هذه ممكن دي او المدورة. اوكي بروفيسور وريني الثانية. فضحتونا.
Next time I'll bring my own. If you make me, I'll bring my own hammer. That's fine. We can always see the
Or
difference.
the rounded ones, the triangle.
Yeah.
حاجة كبيرة كده. They bring us even without this.
This is for a general neurologist, not a neuromuscular specialist.
Yes.
Yeah, but that's okay. That's okay. But then no, I was looking for cross
Rounded on both ends
عايزين
and
كل حاجة
bigger.
يمسك دي. عندكم MRI muscles ما عندكوش حاجة كويسة. Thank you.
I usually also try to see if there are any signs of upper motor nerve involvement in the bulbar region, and there are different ways. Now she doesn't have any bulbar symptoms, and it's clearly more distal in that phase, but good to see. So I used a jerk here. It's not exaggerated, and I can also check the blink reflex, but it's not obviously affected.
This is a common form in Egypt for early onset.
Why do we have two ladies after each other?
Yes. Yes.
Young ladies.
Yes. We have and usually start one lower limb, then the other, then feet drop bilateral and lost reflexes, Dr. I. Usually lost reflexes. I believe that it will be some sort of
And
certain mutation.
no family history in any case.
No, only
No.
her sister has.
query autoimmune, not, no other.
I mean, you have seen many of these
Yes.
young ladies,
Yes.
and
Males,
in
males and
no case there is any indication of a family history.
some of these are familiar. We have about 15 families now in Egypt. Some of these are familiar.
This young onset.
Yes.
Distal.
Yes. How many families we have? About 15 families with this young onset. Yes. I believe you have mutation.
What are you doing?
We started with Professor Albert Rodolphe. He will come next Wednesday. But we need help also.
Yes,
We will need help.
they are.
It looks like
They can
now.
do what can be done in the full.
طيب ماشي خلاص اوكي. هي ممكن تخرج عليه لو محتاجه كرسي وانت خارجه خلاص، لكن خليه برضه في عيانين تانيين. ماشي البسي.
Professor Nagia, I would like to mention that she had whole exome sequencing, and it revealed heterogeneous pathogenic variant in gene IFIH1 for autosomal dominant spastic paraplegia. This is the cause for presentation of the case. Yeah, الريبورت in the يعني في conflicting.
What?
Okay.
What was?
This one.
Show us please.
This one.
ايه؟ طب ما احنا بندور على حاجه because there is clinical trials now for SOD1 mutation, so we are searching for SOD1. في clinical trials دلوقتي بنحاول.
خشوا في ترايل ثيرابيوتيك ترايل.
طبعا yes. They are trying to find anything.
But in this case, you prefer to start any treatment from the previous we mentioned, like Rhinazole or Darafone or Radicava. It may delay the progression.
This was done in our, sorry Dr. Anna, in our National Research Center.
Yeah.
I give everything. I give Rhinazole, I give Edarabone, everything. I give a course of 3 months. If the patient said he feels slightly better or decreased fasciculation, and continue. The longest patient, I give him 9 months, and he was good. The deterioration was not so rapid, but he could pay for the 9 months.
So
Yeah.
recommended forever. If he is okay, he can continue.
Yes.
Yeah, I mean, that's, I think, most of the neurological clinics are trying to prescribe what can be prescribed and hope for the best. So that is, of course, yeah.
What about this gene?
I do not know the gene. In the first place, I have not met this gene, but I would need to go back and see what has been reported, because this is a nonsense variant, and nonsense variants to cause a dominant disease is very unusual. So you have nonsense variants more often acquainted with recessive disorders because of loss of protein, but there are, of course, all types of problems involved with all these. Not all nonsense variants cause actually nonsense, so loss of protein. Some of the nonsense variants may even cause splicing defects. So in biology, you always have these extremes of unusual things happening. So you should not directly exclude anything, but we can, of course, know what is the more likely and the less likely.
But in Egypt, we found families Heradwa with autosomal recessive ALS. That's why we became very interested of searching behind them. I believe with this nonsense variants, sometimes it is not pathogenic or not causing a disease. And especially this is here, it is written, it is heterozygous. So heterozygous, one allele is affected, one allele is not affected. So not sure if this is a cause or not. So I think
It's likely not the cause, but of course, with this data we have and my poor knowledge about that gene, what type of variants you have seen in these dominant spastic paraplegia families, I would have to dig deeper into it to tell more.
We have also many families, Dr. Ayman, with hereditary spastic paraparesis, either with peripheral neuropathy, complicated forms, or not complicated forms. And also, I believe that it's all will be due to genetic mutation.
The phenotype is nothing about SPG.
Yes, it is motor neuron disease or ALS, not hereditary spastic paraparesis.
It's ALS, yes.
So we will search for this gene also. دي العيان عشان دي العيان.
انت هتحطيها على حاجه؟
خلاص عبد الله هيديه لها.
انا هروح البوينتر اهو كده لقدام.
دكتور ايمن you give the presentation to انا فاهم انا اديتهم بس البرزنتيشن بتاعتك اديهم عشان بس يستعجلوا. Dr. Zaim, we are waiting for the EMG equipment to come, not yet. They will be arranged in up floor, so don't worry, they are coming. Because they were in a workshop last night, so they are bringing them. But tomorrow the EMG workshop will be in the 5th floor. القاعة اللي هي فوقينا في الدور الخامس 5th floor. هتبقى I think 501. Same like this, but it will be up. Professor Zaim will be also with us in the EMG workshop. تعالي يا حبيبتي. اسمك ايه؟ حبيبة. ازيك يا حبيبة؟ اقعدي يا حبيبة قلبي. هند؟ هند نايم ولا مدرس مساعد؟ لسه؟ Okay, our colleague Dr. Hind, a resident of the neuropsychiatry department, will present the next case.
Mrs. H.Y.R., 22 years old, female patient, graduated from Faculty of Education, works in clothes factory, lives in El Warraq with no special habits of medical importance. Complaint of the patient, left side weakness, included the face. Family history, consanguinity, no family history of consanguinity. Similar condition, has 2 aunts, maternal side, one is 50 and the other is 33, are wheelchair bound around late 20s due to bilateral upper limbs and lower limbs weakness, not including face and not investigated. Also has 1 uncle, maternal side, also have bilateral upper limbs and lower limb weakness and died at age of 40 due to respiratory and cardiac failure. Medical history and other neuropsychiatric history were irrelevant. The family pedigree, grandfather and grandmother, the 2 aunts and 1 uncle, father and mother, the patient. Past history is irrelevant. The history of present illness, the condition started with gradual onset, progressive course of 5 years duration of left eye ptosis associated with fatigability, no diurnal variation, no diplopia, squint, limitation of the eye movement in any direction, or decrease in visual acuity. Also no other cranial affection or motor or sensory or cerebellar affection. 1 year later, patient developed left lower limb weakness, proximal more than distal, to the extent the patient cannot climb stairs in 1 year, associated with fatigability and with no diurnal variation and no atrophy, hypertrophy, or fasciculation. 1 year later, moreover, the patient developed left upper limb weakness, proximal more than distal, to the extent the patient can't raise her hands above her head. And that was within 1 year, associated with fatigability and no diurnal variation, no atrophy, hypertrophy, no fasciculation. Also, more drooping of left eyelid, deviation, angle of mouth to the right, and inability to close the left eye. 1 year later, moreover, the patient developed difficulty in swallowing to both solid more than fluids and distal weakness on the left only, upper limb more than lower limb, up to patient can't hold object within 2 years, and was associated with atrophy of both left upper limb and lower limb. all through history, no other cranial affection or motor or sensory or cerebral affection fits or disturbed conscious level. The examination, general examination, vital data with normal, no pallor, no jaundice, no cyanosis, no abnormal facies or special decubitus, head and neck, chest and heart, abdomen, skin, no abnormality detected, extremities, atrophy in left upper limb and lower limb, and pseudo hypertrophy of left calf muscle. Local neurological examination, patient is conscious, attentive, oriented to time, place, and person, no dysarthria or dysphasia. Cranial nerve 1 and 2 were intact. 3, 4, 6, the 3 left eye ptosis, no ophthalmoplegia, no squint, no nystagmus. 5, intact motor and sensory. 7, inability to close both eyes, left more than right, or to whistle and mouth deviation to the right, glabellar reflex were lost. 8, 9, 10, 11, 12, no abnormality detected. The motor state, atrophy in left proximal upper limb, thenar and hypothenar, and proximal lower limb, left calf muscle, hypertrophy, and no fasciculation. Tone, hypotonia in both wrist, ankle, and knee joint, and no myotonia. Power, upper limbs, proximal, left proximal, grade 2, and distal grade 3, flexors grade 2, and extensors grade 5, abductor grade 3, and adductor grade 4 of the shoulder joints, abductor and adductor were grade 3 of the fingers, right grade 5. Lower limbs, the left proximal grade 3 and distal grade 4, extensors were equal to the flexors grade 4 and adductors grade 4 more than abductors grade 5, and dorsiflexion more than plantar flexion. Right were grade 5. Truncal muscle, no truncal muscle weakness, and wings of the scapula more on the right. Deep reflex, upper limb on the right all elasted, left biceps brachioradialis, triceps all lost, lower limbs, right all elasted, but left knee diminished and ankle lost. Superficial reflex, bilateral flexor plantar response, pathological reflex absent. Coordination and sensory meningeal signs or skull and vertebral sphincters were no abnormality detected, and gait was limping. This video is 1 year ago.
Asymmetrical condition from the start.
هي من الاول هي فيشن هي بادي ولحد دلوقتي بادي وعباره بادي الناحيه الثانيه بدات تبقى مايند
يبقى لها كام how many years duration
5 years. 5 years duration.
5 years 5 years duration
1 year ago the right facial also affected.
yes بس facial and ptosis at the same time without external ophthalmoplegia. وفي difference between both sides are affected but more on the left side. Yes, severe on the left side. اعتقد دي الحاله كنت بقول لكم عليها امبارح. I mix with the other patients yesterday. Okay. هي حبيبه كنت بقول لكم عليها. اللي يعمل ريفلكس you must unbear the muscles مش يعني unbear the muscles كلها مش قاعدين بنغطي الجوينت وبنعمل ريفلكس. يعني فعلا lost على left side lost hypotonia atrophy.
هو لسه على الناحيه الثانيه ولا
الريسك كمان على الرايت سايد يبقى radiating risk and radiating.
اتنين وخالها، بس خالها برضه كان
maternal side. Maternal side. Very interesting.
Died from what the positive chest?
chest condition, respiratory and cardiac failure. Respiratory and cardiac failure.
Respiratory and heart and respiratory and cardiac, heart failure and respiratory failure. At what age they died?
40.
40. كلهم.
لا لسه اتنين خالاتها عايشين.
The aunts are still living, but can we have the chance to examine the aunts?
ان شاء الله
We
حاضر.
want to examine the aunts.
ماشي حاضر.
Is there any more details on the phenotype of the aunts and uncle? Did they have progressive
They didn't.
muscle atrophy, ptosis?
They have both proximal upper and lower limbs, proximal more than distal, and they will cheer bound.
Atrophies or weakness?
Yes, yes, atrophied, but the distal, they can do the daily activities with their children. Distal is not affected. The face not affected and not investigated. They are wheelchair bound only.
Her onset is younger than the aunts.
Yes, much.
No. At late 20s, they start to be wheelchair bound.
Okay, all the aunts and the uncle?
Around 20s.
Okay, so the same age.
That came case around 20s.
But the face is not affected in the eye. The face is not affected.
Yes.
بس هما الوش عندهم مش بتأثر. She said they are the limbs only, not the face also.
And not distally. They could do the daily activities with their children.
And the grandparents, the maternal grandparents are
Free.
consanguineous?
Free, no.
What do you think, Professor?
This, clearly so. I mean, what you see from the limbs, it looks like a neurogenic cause of weakness and atrophy. And the face is, of course, just unusual. If we have a neurogenic cause of the progressive limb problem, then also the facial issue should be a neurogenic cause, and meaning then asymmetric affection of the corresponding cranial nerves. But that combination is not very easy in terms of known disease mechanisms. The first thing when I see a heavily asymmetric condition, as we have learned ourselves the long way, is a genetic condition that normally causes symmetric problem, but if you have the genetic defect in a mosaic condition, so not all cells have it, just you can have one-sided, then you can have this heavy asymmetric forms, but that's a very long shot.
Situation of weakness of both closure and opening of the eye is usually in myogenic. You can see in the toys and fish.
Is the left arm shorter than the right? Not just atrophic, but also shorter? Atrophic? Because when I see the... So, yeah. Ask her to stretch it out.
مقاس الجزمة في اليمين زي الشمال ولا في فرق؟ مفيش فرق؟
It is progressive more in the last year. I didn't see the patient in 1 year. It is more progressive.
Yeah, if you're losing cranial nerve nuclei, you can have ptosis as well. So that's the question: how's the brain MRI look? And yes, and a needle in one of the facial muscle will tell you whether there's a neurogenic process or not. If you put a needle in one of the facial muscles. This arm is shorter than the. You can see that. It's not just atrophy. It's this the left.
It is a
You
cerebral
watch it?
hemiatrophy because all the left side is affected.
Yeah.
Not much, but maybe some. I mean, if the arm is shorter, it would mean that the process has started a longer time ago.
That's why it is very important to examine the arms because is it the same
Yeah.
disease or a different disease?
Yes.
We must examine the relative.
And at the same time, collect the DNA of all family you can collect. There was just one aunt alive.
Two aunts alive.
Two aunts alive.
And one
Yeah.
uncle
The uncle
died
was
at age of 40.
okay.
There is bulbar in this fee bulbar?
Counted that the dysphagia solid more than fluids. There's no joke. Bilateral. Dysphagia to solid more than fluids.
Dysphagia to solid or
To both, but solid more than fluids.
solid more?
هاتي راسك تحت زقي الدكتور براسك براسك
So no definite
لورا
indication of upper motor neuron.
The muscles are bilateral supplied. That's why neck flexing.
Yes.
So has she had a brain MRI?
ليها برين عملنا برين MRI.
Who's normal؟
No
You have
atrophy.
معاكي رنين
اه يا دكتور اه يا دكتور لا يا دكتور انا مصوراه
انت مصوراه؟
عشان هي
Because we thought about hemiatrophy and especially the right side looks breast and this side lost. خلاص مش عارفه دي
بتاع رجلي.
طبعا
And neurophysiology.
البرين MRI is okay.
اه يا دكتور كان نورمال والام ار اي سيرفايكال كان في عادي نيك ماسل سباز.
MRI cervical normal.
اه
What about the neurophysiology?
الام ار اي اول هول باد ماسل اديما ات ذا gastric
MRI muscles on the left side are marked atrophic
yes
in contrast to the right side. But is there any fatty infiltration?
no edema only at the gastrocnemiae of the right.
Soleus.
Yes.
No.
Soleus? Yes. As if selecting the soleus muscle.
And on both
ده
sides.
الكاف ليفل اللي قلنا عليه امبارح يا جماعه ودي soleus muscle. There is fatty infiltration. So there is a selective muscle disease
And also peroneal.
and peroneal muscles.
صورة
We showed them rapidly yesterday some muscle MRI so they can understand that. Do you see the left side?
It's all unilateral? Or
Yes.
No, bilateral on the lower legs.
Yes, that's
Yes. But Professor, can you
More
see
on the left.
the gluteus maximus on the left side? Complete fat infiltration in contrast to the right side.
She did nerve conduction only on left median nerve and was average values. And the muscle ultrasound, she also did it, patchy myopathic features, hyperechogenicity, and fatty infiltration, and affecting the left side. She didn't do EMG.
I'm sorry. لا she did. عملت رسم عضلات. حطوا لك الابره في ايديكي.
بس
لا
هو
عملت بس اكيد
nerve
بص منك هنا.
هو النيرف كوندكشن EMG مطلع كده بس.
لكن she did EMG.
بس هو ده الفايندنج ده بس.
No, it must be repeated. Especially the muscles affected.
ما انا هعمله لها تاني.
يعني هنعرف أنهي
انا هعمله لها تاني فعلا.
That's why tomorrow we will have EMG workshop. Nerve conduction EMG basics and hands-on, because this EMG nerve conduction is not accepted.
ما انا عارفه.
عرفتوا ليه عايزين بقى يقولوا لا احنا عايزين advanced. لا we need the basic EMG nerve conduction again.
أكيد عاملة يعني.
اكيد لا اكيد.
Can we exclude a myogenic condition?
ماشي انا عايزه التحقيق بس بتاعه.
Not with this, not right now.
No, no, I would not.
No, I can't.
What's your opinion regarding
No,
the
she has,
mitochondria?
EMG?
she has another one. I'm sorry. She has another one. It shows myopathic changes in the muscles. They did proximal and distal muscle.
See, when there's doses and eye closure and open mode weakness,
Uh-huh.
you can't do
But
that.
I don't think that she did a facial. I'm sorry, just a moment. Needed EMG was done, and they took the both genioglossus and trapezius, left biceps, brachii, triceps, tibialis anterior, showing highly polyphasic motor unit potentials with shorter duration and early recruitment. So they found myopathic
Yeah.
changes.
Yeah,
And
I
the
would.
EMG of lower limbs, the left vastus medialis, showed broad, relatively large motor unit potentials. EMG of both deltoid, right biceps, and first dorsal interosseous also shows normal. But mainly it was myopathic.
Unrefractory study. That was the right side she's talking about.
The right side is normal. Yes.
Can she come tomorrow?
Sorry?
Can she come tomorrow?
For the.
Yes, we can do for
Mm,
him.
yeah.
Okay. دكتور عايز اعمل لك رسم عضلات.
Yes, I mean, if you see the ptosis, the first and unilateral ptosis, you would first, of course, think of a mitochondrial disease. But usually that needs to be accompanied with some sort of ophthalmoplegia. And if you don't have any ophthalmoplegia, then mitochondrial, difficult. I would say in this situation also considering the MRIs with the rather selective fatty replacement in soleus and peroneal muscles, it is clearly more myogenic than neurogenic. You would expect a more diffuse affection of all muscles in the lower limbs with the neurogenic condition. And in fact, we have not so long ago, maybe 1 year ago or so, reported large deletion in the nebulin gene, causing the closest I can come to this case, asymmetric involvement of limbs and face. I can't recall exactly ptosis, but definitely at least some lower face weakness, and it was not this severe, but that is the closest I come, and that was a mosaic. Mosaicism of that big deletion in nebulin gene. So I would definitely go for genetics, and then you would need very elegant CNV detection systems to go for the rearrangement.
I'll also add has she had a pathology? Has she had pathology? Muscle biopsy or not? Scheduled? Any particular muscle? Which muscle are you good for? Which muscle?
هي ما عملتش، هي عملت هتعمل.
We will take sure. We will take DNA sample for the first boy, Muhammad, and for Habib. And tomorrow we will do neurophysiology. It will be very interesting to do neurophysiology for Habib. This will help much in her diagnosis.
But also the larger family, I would go as much as possible for. Yeah. Also healthy members, I would collect DNA.
مين يمسك الحد؟ دكتورة رب، ست يوسف، دكتورة يسرا معاكي. We want the large family, the healthy and the affected, because if you find a mutation, you must search this is a true mutation or not, and to see the healthy relatives also. Yes, yes, and consent, please, genetic consent, please.
Did you say you have a muscle biopsy already?
في muscle biopsy.
لا لسه هتعمله
Yeah,
لسه schedule.
will be.
From where will take the muscle biopsy? What do you think? Because the left side is marked atrophic and fatty.
I'm not too sure because we'll have to do bilateral, and it may be I haven't examined her. It's possible that she may have bilateral because the MRI showed she did have some bilateral features, isn't it? So this is a patient. I'll give him a lecture tomorrow, but this requires a very thorough exam to pick up some subclinical find, which you don't see. Obviously, the left side is worse, but I would think there's some involvement of the right side as well. I don't know. MRI is showing. And that's how the needle is important because then you pick up mildly affected muscles. That's why neurophysiology is so important.
That's why I want everyone who be specialized in neuromuscular disorders to do the nerve conduction EMG by himself, not by his colleague, because he's searching for something. You must do the neurophysiology. Even if your colleague will do it, please, you must do your patient by yourself. اتفضلي يا فندم. لا مش سامعين صوتك خالص.
Okay, I just have a quick question. You mentioned earlier, Professor, that it might be a mosaicism or affection of some cells in the body. I want to understand more about this. Could this be inherited form from the aunts and the grandmother, or would this be happen only in utero for this patient only?
So we have reported two different large deletions in nebulin gene. The one was segregating in the family, causing a dominant disease. And in this asymmetric mosaic patient, we recently reported it was sort of de novo. It could not be detected in the parents. Which means that at the early stage of the embryo, maybe in the two-cell situation, one cell got the mutation and the other not. So half of the cells then continued with the mutation and half of the cells did not continue with mutation. Anything can happen.
Thank you.
Okay, thank you so much for my colleagues in neuropsychiatry department for the very nice and excellent cases. Thank you, residents and assistant lecturers and lecturers for all the effort you did through the last 2 months.
Difficult cases.
Yes, very difficult. And still we have a lot after the break. So I will be very happy to present my colleague, Professor Dr. Ayman Nasif. He came today to talk about congenital myasthenic syndromes, and he will try to simplify, Dr. Ayman, as you can, so our colleagues will know about congenital myasthenic syndrome. Yesterday we have some cases of congenital myasthenic syndromes.
بسم الله الرحمن الرحيم. طبعا في البدايه بحب اتوجه بالشكر للاستاذه الدكتوره ناجيه to invite me to be with her in this elegant symposium, and also want to welcome our dear guest, eminent professor, to be with us in Egypt for maybe third or fourth time, and want to see them yearly inshallah. We want to simplify as much as we can the congenital myasthenia. In the past many years, we didn't have important concentration on this because we thought that there is no much treatment or hope for patient diagnosed as congenital myasthenia. But alhamdulillah, recently in last years, we find many treatment options for this patient. The pediatric myasthenic syndromes, the myasthenic syndromes are due to defect in the transmission at the neuromuscular junction. Myasthenic syndromes in children has three distinct forms, pathophysiologically different mechanisms. All forms of myasthenia lead to muscle fatigue and weakness of varying degrees. The fluctuation of the weakness are the hallmark in these disorders. Firstly, the juvenile or pediatric myasthenia, these three groups. Today we will concentrate on the first group, which is the congenital myasthenic syndromes. They are group of genetic disorders that lead to muscle weakness through structural or functional abnormality of the proteins involved in the neuromuscular transmission itself. Second type, which is a transient neonatal myasthenia, the infant due to transplantation or transplantal transfer of the maternal antibody of the myasthenic mother, and these types will be transient. If the patient passes in the few days or few weeks, he will be normal after that. The third time is the autoimmune juvenile myasthenia gravis, like adult, but it starts in young age. It's autoimmune disorder. We must know specifically the structure of acetylcholine receptor and the associated proteins, because in the congenital myasthenic syndromes we have defect in many causes, and some of these causes due defect in the associated proteins to the acetylcholine receptor, like rhabsine and MuSK, which have antibody in the adult and some cases of pediatric autoimmune myasthenic syndrome. And this MuSK is associated with the LRP protein, which attached to agrine, and this association with agrine and the LRP protein is essential for synchronization and normal transmission and normal function of acetylcholine receptors. Like this picture, if we have defect in the anti-MuSK, will be there is disturbance in the clustering of the acetylcholine receptor, and this disturbance will interfere the normal function of the acetylcholine receptor and will lead to defect in the transmission and function of the neuromuscular junction. This is also another picture for acetylcholine receptor with the associated LRB proteins and the associated rhabsine and DOC proteins. The congenital myasthenic syndromes are not autoimmune disease, but are a group of disorders caused by alteration in the structure or function of the protein in the neuromuscular junction. This disorder must be suspected to distinguish them from the myopathies or other neurogenic conditions. The congenital myasthenic syndromes are highly heterogeneous, both clinically and genetically. There is about more than 30 genes have been linked to congenital myasthenic syndromes, with the rate of discovery having rapidly accelerated over the last decades due to the decreased cost and availability of the next generation sequencing. As we see, many patients are due for them genetic study, but unfortunately most of them are not. It's okay. This is a general classification of the congenital myasthenic syndromes. The first type will be maybe presynaptic, and second type will be synaptic space, and third type, which is the most common type, is the postsynaptic, and more than 50% will be due to primary acetylcholine receptor defect. And first type, which is the presynaptic, due to choline acetyltransferase defect or synaptic B25B, and all of them are not this protein, because the function of Botox, when inject the Botox, will interfere with the synap 25 protein. We'll start by the first type with presynaptic types. The presynaptic syndrome with the choline acetyltransferase deficiency lead to the choline acetyltransferase, which is catalyze the synthesis of acetylcholine from acetyl-CoA and choline in the cholinergic neuron. The diagnosis is suspected clinically when you are treat children with sudden attacks of unexplained apnea, episode of apnea provoked by stress or without apparent causes, occurring in patients with a few or no other myasthenic symptoms. So the main presentation, or maybe the only presentation in these children, sudden attacks of apnea. Some patients are apneic and hypotonic at birth. Others are normal at birth but develop apneic syndrome during infant or childhood. So you may face some children in the childhood age in the school. We have unexplained attack of apnea. So in them you must think for this presynaptic syndrome of congenital myasthenic syndrome. However, the apneic attack also occur in another causes of congenital myasthenic syndrome, like rare causes of sodium channel myasthenia or other mutation in rhabsine protein. A clue to identify the disease gene came from the discovery that subtethanic stimulation will reduce the amplitude of the combined muscle action potential to more than 50% below the baseline. Normally, we may have decreased, but less than 30%, followed by slow recovery over 5 to 10 minutes. A marked decrease in the compound muscle action potential amplitude after subtethanic stimulation. Also, we see them in other congenital myasthenic syndrome, but the main difference that the recovery. Here, the recovery will take more than 5 to 10 minutes. In the other types, the recovery will be in less than 5 minutes. The second type is the synaptic basal lamina associated syndrome. The end-plate acetylcholine esterase deficiency due to mutation in the CoQ protein. The end-plate species of acetylcholine esterase is asymmetrical enzyme composed of 3 homotetramer of globular catalytic subunit, as we see these 4 proteins. And this is attached to the triple strand of the collagenic tear, which is the CoQ, which is the main causes of mutation, is this CoQ protein. That anchor the enzyme will lead to attachment of this enzyme to the synaptic basal lamina, as we see in this graph, the different proteins in this CoQ protein, which may many mutations. Also, this picture will show the location of the acetylcholine esterase receptor, which attached with the CoQ protein to the MuSK receptor, and its disturbance will lead to the congenital myasthenic syndrome, as we will see the causes. The synaptic current and potential are prolonged due to extended lifetime of acetylcholine in the synaptic space. The nerve thermal are abnormally small and decrease the number of quanta available for release. Mutations have now been identified in each CoQ domain. Depending on their locations, they may prevent the collagen domain from associating the catalytic subunit, or prevent assembly of the triple helical collagen domain, or reduce the expression of the assembled enzyme. So severely affected patient presented maybe in infancy, less severely affected patient will present in childhood and became disabled later in life. The clinical picture will be weakness can affect all voluntary muscles but may spare the ocular muscles, and in few patients it may have limb girdle distribution. Specifically, it has a specific treatment with ephedrine or albuterol is beneficial, but the effect must take several months. So you should give patient a long time to examine the benefit of the drug. You must stay for few months or maybe longer to detect if it's efficient or not. Don't stop the drug early. The second time will be a congenital myasthenic syndrome due to laminin B deficiency. The laminin B2 is encoded by laminin B2 gene, is highly expressed in the basal lamina of the eye and the kidney and the end plate. At the end plate, laminin B2 align the nerve terminal with the postsynaptic region and regulate the trophic interaction. Here specifically, the patient may be worsened by iridostigmine. Don't give them iridostigmine, but improve as a first type by ephedrine. The third type is the postsynaptic defect, which is the main type. More than 50% will be caused by defect in the acetylcholine receptors. The acetylcholine or nicotinic acetylcholine receptors stem from molecular defect in the muscle nicotinic acetylcholine receptor, an integral membrane protein with subunit combination. Have 5 subunit protein, 2 alpha and 1 beta and 1 delta, and in the adult will be E or epsilon, and in the fetus will be gamma protein. As the normal end plate potential acetylcholine is concentrated at the crest of the junctional fold, as we see in this picture, this is the site of concentration of acetylcholine receptor. If there is defect in this acetylcholine receptor, congenitally or at autoimmune, will be the structure of the morphology of muscle membrane. The congenital myasthenia syndrome caused by primary acetylcholine defect, the cause is substitution of the fetal gamma subunit for the defective E subunit, resulting in end plate acetylcholine receptor content is reduced markedly, approximately about 10% of the normal concentration. The synaptic response to the acetylcholine reflected by the low amplitude of the miniature end plate potential and the miniature end plate current is markedly reduced. Nearly all patients have eyelid ptosis, oculoparesis, that often become fixed and variable, but frequently moderate to severe limb muscle weakness. The second type, which also is common and treatable causes due to kinetic defect in the acetylcholine receptor. We have 2 types. Within the postsynaptic congenital myasthenic syndrome are a specific acetylcholine receptor kinetic abnormality that result in either abnormally brief acetylcholine receptor opening, which is called fast channel syndrome, or abnormally prolonged acetylcholine receptor channel opening, which is called slow channel syndrome, with a corresponding effect on the end plate current duration and deleterious effect on neuromuscular transmission. First type, which is the slow channel syndrome, also has 2 causes, either mutation in the ligand binding domain, which enhance affinity of the acetylcholine by slowing its dissociation rate from the receptor, so the acetylcholine will be attached to the receptor for a long time and will do its effect for a long time. The second cause is mutation in the BOR domain, which enhances the steps in the process of the receptor activation and subsequently agonist binding, so the acetylcholine will be binding to the receptor for a long time. Either mechanism will lead to prolonged single channel current and will be lead to end plate current and end plate potential, while mutation in the BOR domain also causes spontaneous channel opening. Also, we find spontaneous opening without nerve impulse. During activity, successive prolonged end plate potential will lead to progressive depolarization of the postsynaptic membrane, which lead to depolarization block. The prolonged as well as the spontaneous opening of the channel will result in calcium accumulation in the postsynaptic region and finally will lead to end plate myopathy. This causes loss of acetylcholine receptor from the junctional fold, as we see in the previous picture, and will lead to altering of the end plate geometry. The slow channel syndrome usually present in the first decade, but severely affected patient may be presented at neonatal period. There is selective severe involvement in the cervical and the scapular and dorsal forearm muscles. The ocular muscle is usually spared. Some patients have mild asymmetrical ptosis. By rhodostigmine worsening the disease by increasing the end plate myopathy, but long-lived open channel blocker of the acetylcholine receptor like quinidine or quinine or fluoxetine, which is SSRI, is gradually improve and even remove the symptom totally. So as we said before, now it is treatable condition. The second type, which is the fast channel syndrome, is caused by recessive mutation. It is a physiological opposite to the first type. It's opposite to the slow channel syndrome. So the current, there is end plate current delay abnormally fast, is closed very fast. The channel opening are abnormally brief, so the amplitude of the synaptic current and synaptic potential is reduced. The severity of the clinical sequencing are variable according to the site of the pathogenic mutation, and the therapy is mainly by 3,4-diaminopyridine and pyridostigmine. The treatment is totally opposite to the first time, which is the slow channel syndrome. The third type is a different defect in the end plate development and maintenance. There is mutation in many protein, as we see in the first picture. There is many proteins associated to the acetylcholine receptor protein. It's important to maintenance of this normal function of end plate potential, like MUSC, like neuronal agreen, like LRB protein, DOC, and rhabsine, which form signaling network essential for end plate development and maintenance. Any mutation in this protein will lead to abnormality in the end plate potential and development. Last type is the congenital defect in the glycosylation, because glycosylated protein are present and all end plate side pre and post synaptically, and safety margin of the neuromuscular transmission is likely compromised by combination of pre and post synaptic defect. This is no need for this one. Diagnosis and management. The genetic diagnosis is suggested by this tetrad. First, fatigable weakness, that is the most profound in the ocular and other cranial muscle, pediatric age of onset, negative antibody for myasthenia gravis testing, and last one is supported by electrophysiological data in the form of decrement response upon slow repetitive nerve stimulation. Also, if there is available single muscle, EMG will be very helpful. Most congenital myasthenic syndrome are autosomal recessive mode of inheritance, rendering positive family history is not essential and not important in the diagnosis, except the slow channel kinetic syndrome, which is autosomal dominant. This is specific for nerve conduction for congenital myasthenic syndrome, which are called double motor response or double compound motor action potential to a single nerve stimulation. We see this doubling of compound muscle action potential. This one too, it's not only one response, but doubling of the compound muscle action potential. Sometimes you are called the repetitive compound action potential, is specific for congenital myasthenic syndrome, specifically for COL-Q mutation and for slow channel syndrome mutation. Approach to therapy. There is two major treatment strategies that reflect broad pathophysiological dichotomy of congenital myasthenic syndromes of having either decreased or increased response to acetylcholine at the neuromuscular junction. First one, when synaptic response to acetylcholine is decreased, the cholinesterase inhibitor and 3,4-diaminopyridine are used to increase the amount of acetylcholine released into the synaptic cleft. The second type, when the synaptic response to acetylcholine is increased, add in the slow channel syndrome, which will spontaneously opening and will prolong it for a long time. Here, the channel the channel will remain opening for a long time. So, opening channel blocker like quinidine and quinine and fluoxetine, which is SSRI, are highly beneficial for this type of syndromes. Also, the adrenergic agonists like salbutamol or albuterol and ephedrine, which don't have a well-established mechanism of action, may help in many types of congenital myasthenic syndrome. So you may add this salbutamol to either types if there is a refractory response to each treatment. Rapidly, this pyridostigmine and 3,4-diaminopyridine pyridostigmine by inhibiting acetylcholinesterase in the synaptic basal lamina, which increase the number of acetylcholine receptor activated by single quantum. The 3,4-diaminopyridine increase the number of acetylcholine quantum released by nerve terminal alone, and specifically in combination, they may increase the amplitude of end plate potential and thereby safely margin of the neuromuscular junction. Thus, they may be beneficial in patients with end plate acetylcholine deficiency and also in fast channel syndrome. Fluoxetine and quinine are long-lived open channel blocker of acetylcholine used in the treatment of slow channel syndromes. The adrenergic agonist, as we said before, it may be helpful in many types like mutation in the COL-Q component and DOC and laminin B2, as well as in some patients having low response to other medications. To conclude, performing a genetic analysis for a specific mutation causing congenital muscle syndrome is necessary to direct the treatment for that specific syndrome. Treatment modality for congenital myasthenic syndrome caused by one mutation may actually be harmful to the patient if a different mutation is present. So before treatment, you must do genetic analysis. As we said before, there is many treatment may worth the other type of mutation. And the treatment must be tailored to specific mutation causing congenital muscle syndrome. Making distinction between congenital myasthenic syndrome and juvenile myasthenic syndrome also will sometimes be difficult, specifically if there is negative antibody to acetylcholine receptors. This will illustrate or conclude the different therapy for each syndrome. If we have choline acetyltransferase deficiency, the treatment will be mainly by pyridostigmine and parental neostigmine. If you have acetylcholine receptor deficiency, the treated mainly by albuterol or ephedrine. If you have laminin B2 deficiency, the treated mainly by ephedrine. Simple acetylcholine deficiency, the treated mainly by pyridostigmine and 3,4-diaminopyridine. And as we mentioned before, albuterol also may be helpful in refractory cases. Slow channel syndrome, quinidine, fluoxetine, opposite to the fast channel syndrome, which will be beneficial by pyridostigmine and 3-aminopyridine, and the other is contraindicated. Is contraindicated to use this kinine in fast channel or to use pyridostigmine in the slow channel. Rhabsine gene and the muscle deficiency, pyridostigmine and 3-aminopyridine will be beneficial. Doc myasthenic syndrome, the trial also for salbutamol, agrine and LRB deficiency, there is also some beneficial response to ephedrine and salbutamol. This last slides will give you some clue clinically to some syndromes. Like if you have dominant inheritance, this will be found in the slow channel congenital muscle myasthenic syndrome. If you have refractory or worsening by acetylcholine inhibitor, you must think in the COL-Q mutation. If you have repetitive compound muscle action potential, you will think in the slow channel syndrome and COL-Q mutation. If you have congenital contracture, you will think in rhabsine and acetylcholine mutation. Greater than 50% decrement or decrease on compound muscle action potential, you will see them in choline acetyltransferase deficiency. Sudden apneic syndrome will think in the choline acetyltransferase. If you have nephrotic syndrome and the ocular mutation, you will think in laminin B2. Thank you.
Professor Ayman Nasser, thank you so much, my dear colleague, because of trying to simplify these very difficult syndromes. It is very important, as you see, to do genetic study and to correlate with the clinical phenotype and to use this table to try to know the mutation and to give the important or the suitable drug, because some drugs may be harmful to the patient. And still, Dr. Ayman, our insurance is refusing to do genetic study and whole exome or even targeted genes. They are refusing to do. Please consider the neuromuscular unit in your documents, because we have many of these cases, and we hope that you help us. Professor Zaim Siddiqui has a great work in myasthenic disorders and myasthenia. We will have a talk next Thursday. What you think about congenital myasthenic syndromes?
It's a rare disease, but hard to diagnose initially. Many of these patients present with myopathic features, and particularly if they don't have ocular involvement, it becomes. I remember a patient who in Canada went for muscle biopsies and finally presented to us. And in these patients, I think, again, I'll come back to it. Neurophysiology is very important. Yes, genetic testing, but first you have to suspect the condition. And neurophysiology in these patients is nearly always shows a decremental response, which I'm going to show you tomorrow. And so the first order of the day is to suspect the condition, particularly in children who can't give you a provide history of fatigability or whatever. But so I think in that regard nephrology helps a lot by confirming it's a neuromuscular transmission defect, it's a junction defect rather than a myopathic condition. And then many of these require specialized testing. Not all are diagnosed by genetics. Some require specialized ion channel studies. So the field is still evolving. There are 30 genes identified, more than 30 actually now, and the field is still evolving. So that's my say. Thank you.
Yeah, I fully agree. You have to think of it because we have seen that in Finland with DOC7 that several patients, they do not always have the clear ptosis. They were referred as limb-girdle muscle diseases, and then when everything came out negative, and of course, again, muscle imaging. If you see nothing on muscle imaging, then think of myasthenia.
Thank you so much. So thank you so much. We'll have a break for half an hour. Then we'll be here again to have more lectures and more cases. Thank you.